All right, good afternoon. I'll call this roundtable to order. Today is Tuesday, September 30, 2025. The time is 1 p.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. We are holding this roundtable to hear from public and leadership of our district's managed care organizations regarding challenges and opportunities in our delivery of healthcare to individuals under the DC Medicaid program. This is the first roundtable where we're here directly from our MCO leaders regarding their delivery of services, their operations, the challenges and opportunities to improve health outcomes. Since 1994, the district has enrolled children and families, pregnant women and children and adults with special needs in managed care, which covers acute primary care, specialty, and certain behavioral health services. As of June of 2025, there were 240,000 people, actually over 240,000 people, approximately 88% of all Medicaid enrollees were enrolled in these Medicare plans. Currently, the Department of Healthcare Finance contracts with three managed care organizations to serve DC's Healthy Family Program. WellPoint, which is formerly known as AmeriGroup DC, AmeriHealth DC, MedStar Family Choice DC. And Healthcare Finance also contracts with the Health Services for Children with Special Needs, also known as HSCSN, to provide access to services for children and adolescents, Supplemental Security Income Program. In 2024, Healthcare Finance released a 5-year quality strategy for the MCOs focused on 5 goals. First, ensure access to quality and whole person care. Second, improve management of chronic conditions. Third, improve population health. Fourth, ensure high value appropriate care and improve the clinician experience. MCO contracts are some of the largest government contracts that we have in the district. In 2022, the district spent nearly $2 billion on services administered by the MCOs. By FY24, nearly 2/3 of provider payments paid by healthcare finance were in managed care. The MCO model was designed to control costs by paying MCOs a lower per member per month rate than traditional fee for service. However, during the FY24 performance oversight hearing, the Deputy Mayor for Health and Human Services noted that the spending pressures for FY25 were increasing due to enrollment growth and rising reimbursement rates, resulting in a higher projected cost per beneficiary. While MCO model holds great potential to improve care and reduce cost, its success depends on strong oversight, transparency, and alignment between the financial incentives and the health outcomes. We have a responsibility to ensure that the Medicaid managed care system works for residents who depend on it, and I look forward to today's testimonies and ideas of how we can work together to deliver greater accountability and improved health improvements. All right, we have not been joined by any of my colleagues yet, but there are some who are in the building and around, so they may be joining us in a little bit later. We're going to first hear from our public witnesses, and then we'll turn to our managed care leaders to provide their remarks. For those who are wondering, where's the Department of Healthcare Finance? They testified earlier this year and will be back before us, I think, in November or in a couple of weeks. So nonetheless, they will get theirs too. Don't you worry. We will see Director Turnage. Okay, for our public witnesses, now, friends, I appreciate everything that everyone has to say, but everyone has 3 minutes to testify because we all want to get out of here at an appropriate hour and we want to make sure that everyone has an opportunity to speak. So when you come to the table, there is a little timer that's right there in front of you. When it hits yellow, it works like red light, green light. When it hits yellow, that means it's probably time to wrap up. And we'll go from there. And then we'll turn to our virtual witnesses. And for the virtual witnesses, we'll talk a little bit about that once we bring those folks on. All right. So I have 4 seats. So I'm just going to call till I get 4 people. All right. Chris Gamble, behavioral health policy analyst at Children's Law Center. Crystal Jackson, a certified doula, a Queen Mama Doula Services. Gina Vallo, owner of Birthing Kind. All right. And Jimmy Williams, Washington Literacy Center. I don't see Jimmy. Okay. Jacent. Oh, there she is. Okay, great. All right, Chris, when you're ready.
Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Chris Gamble, and I'm a Behavioral Health Policy Analyst at Children's Law Center. Thank you for the opportunity to testify today about the managed care organizations in the district's Medicaid program. DC spent nearly $2 billion in 2022 on services administered by MCOs. Managed care holds promises of improved access to care and health outcomes, along with overall decreased healthcare costs. But we must have reliable and enforced accountability processes to ensure high performance so that these possibilities are realized. My written testimony contains more details about what I will now highlight regarding systemic communication gaps that disrupt children's healthcare coverage, inconsistent quality of case management services, and how to improve MCO behavioral health performance metrics. The systemic issue that needs to be addressed involves delays between a child qualifying for SSI and that information being available to HSCSN to confirm eligibility. This impedes access to care. We also have concerns about children losing coverage. We had a client who stopped receiving SSI due to parental income change, but the child still had a qualifying disability. Mistakenly, this child was dropped not only from HSCSN coverage, but Medicaid altogether, delaying access to much needed medication. System integration between Social Security, DHCF, and the MCOs needs to be efficient so access to care is streamlined and not improperly lost. Case management is one of the services that gives MCOs the ability to support enrollees with navigating the health system and getting connected to needed resources. Some of our clients have had experiences with case management that show us there can be successes, but there are also opportunities to raise the standards of the service. In one client's case, a case manager attended progress meetings when the child was receiving inpatient care, helping to set up post-discharge services. This took the burden off of their parent who was stressed from navigating the healthcare system for their child with complex needs. However, for another client who needed therapy, their case manager provided a referral list which simply contained a list of names. This falls short of the expectations of case management, leaving families with more tasks to complete without specialized support. Lastly, the health system can benefit from stronger behavioral health network adequacy standards that lead to meaningful improvement in care. In order for any changes to be truly impactful, however, a new date for the carve-in of behavioral health services must be set so our MCOs have the ability to administer all the care their enrollees receive. Thank you for the opportunity to testify, and I welcome any questions you may have.
Thank you, Chris. Crystal?
Greetings, Councilmember Christina Henderson and Committee on Health. My name is Crystal Jackson, owner and operator of a Queen Mama Doula Services, doula equity consultant, serving as co-lead for the Doula Learning Action Collaborative, as well as a co-chair for the Ward 8 Health Council Maternal Health Working Group. I am disheartened today to have to share the numerous pain points in implementation for the doula Medicaid benefit, including lack of support for doulas acclimating to the DC Medicaid doula benefit. My written testimony will share more of my experience, and so I'll just let you know that I have been a part of the tapestry of the district's maternal health work since October of 2022, including serving as a chair for a subcommittee of the perinatal mental health task force. During this time, I also began my journey to become a Medicaid enrolled doula provider. And the general steps a doula must take are first to enroll with DC Healthcare Finance and then individually enroll with each MCO. After having to advocate to include BIPOC-centered doula training entities to the approved list of doula certificates, I was finally able to enroll in DC Healthcare Finance. It took about a year for me to complete that step. And that's unacceptable. It deters doulas from considering to enroll, and it also delays families' access to doula support. But even more cumbersome, and the topic of this roundtable, is what I've gone through to enroll with MCOs in DC. I've been unsuccessful in enrolling with 2 of the MCOs, and there is a clear lack of guidance, communication, and dedicated resources to support doulas. After a lengthy process, I did establish a contract with 2 other MCOs, which took about 6 months. I began offering services to WellPoint families this March 2025. However, as of today, I still have not been reimbursed for the services my team and I have provided families. And because I have not received payment, I've had to pause my contract with WellPoint, which means families that were receiving postpartum care had to be cut short. And I also had to turn away new families that were expecting care from my team and I. I became a Medicaid provider with the hope that more families would have access to our services, which they do, but I need to be compensated for those services. My ask today is that MCOs should have easily accessible technical assistance so doulas can understand how to enroll and bill for our services, and that MCOs would work in partnership with doulas and in partnership with each other to, again, create an easier access point for doulas looking to enroll in the benefit. The more complicated this process remains, less likely are doulas and families to engage in this benefit. And I want this to work and have been leading the charge to do so through my doula equity work. And I thank you for the opportunity to testify and welcome any questions.
Thank you, Crystal. Gina?
Good afternoon. I'm Gina Vallow, birth doula and owner of Birthing Kind, a group of 3 doulas serving Medicaid enrollees in the District of Columbia. I'm here to share the real-world barriers that we face in credentialing, contracting, and billing for Medicaid services in the district, and how this directly delays care while straining small doula businesses. I started the credentialing process with 3 of the 4 MCOs, AmeriHealth, WellPoint, and MedStar Family Choice, a year and a half ago. I have yet to operate effectively or efficiently as a network provider with any of these organizations while continuing to provide doula services to their enrollees. Disorganization and a lack of communication is a common theme, with one MCO losing my paperwork, never sending a contract, and identifying no contact person, causing me to turn away families who were otherwise eligible. Another MCO applies coding and billing rules inconsistently, resulting in routine denial of claims and regular appeals, often for claims identical to those previously paid. Each MCO has unique, unpublished requirements that can only be learned through trial and error. Another MCO made an error in our contract by omitting postpartum care codes, which was discovered only after thousands of dollars in postpartum claims were denied. This issue was identified back in February and still has not been resolved or paid. We had to stop providing postpartum care altogether, ending our client relationships in their hospital rooms an hour after giving birth. We also had to stop supporting a mother with stage 4 breast cancer who ended up missing radiology treatments because there was no one to care for her newborn in the waiting room. That is not an abstract administrative problem. It is direct interruption of life-saving support. I've spent hundreds of hours on phone calls, follow-up emails, claims resubmissions, and appeals, time that goes uncompensated. I have only been able to devote this time and accept the risk of non-payment because of outside income and personal savings. Most community-based providers do not have that privilege, and that undermines access and equity for doulas and DC residents alike. We can start to address these issues by implementing a single credentialing process, clear, consistent public billing guidelines for doula services, service level agreements for credentialing, contracting, and clean claim payment with automatic penalties and interest, requirement of auto reprocessing and retroactive payment when denials trace to roster and contract errors, and quarterly publication of key metrics such as turnaround times, denial reasons, and prompt pay performance by MCO. I'm happy to offer my support to any and all efforts to implement these fixes. Thank you for your time.
Thank you. Ms. Brown?
Honorable Chairperson Henderson, my name is Dr. Jacinthe Brown, and I'm the Chief Impact Officer at DC Central Kitchen. Public health is a priority for DC Central Kitchen, and we have been a proud partner of this committee in working to advance the social determinants of health in the DC communities where these essential assets and resources are the hardest to find. We know that ensuring Medicaid patients are able to access training, employment, nutritious food, and wraparound support services is the right thing to do based on our values and mission. We also know that such efforts are also some of the smartest methods we can employ to ensure our healthcare dollars are spent well and in service of lasting patient health. The district has been clear in setting expectations that its MCOs take real action to address the social determinants of health. I'm pleased to say that from DC Central Kitchen's perspectives, that expectation setting has been met by MCOs. We have become robust and thoughtful partners in our mission and programs. WellPoint DC, formerly known as AmeriGroup DC, has spent more than 2 years building a strategic partnership with our Culinary Job Training Program, or CJT. CJT provides robust knife skills and life skills training to DC residents who have experienced employment barriers like homelessness, incarceration, and addiction, all at no cost to our students. Thanks to our partnerships with WellPoint DC, we have a much deeper understanding of the role that Medicaid plays in our students' lives and how much overlap there is between the Medicaid patient population and our student population. In the past 2 years, CJT has served 170 Medicaid patients served by all 3 DC MCOs. Through our partnership with WellPoint DC, we have the ability to connect patients served by WellPoint DC with additional case management, resources relating to essential services like housing and rent support. Their staff have volunteered in our kitchen to prepare meals for DC's children, seniors, and veterans, and attended our CJT graduations to celebrate our students' accomplishments. We have also attended WellPoint DC's annual patient resource fair, educating hundreds of patients about DCCK resources like CJT or our Healthy Corners program, a vital access initiative this committee knows very well. Since 2024, WellPoint DC has invested more than $192,500 in our training program and core services, allowing us to expand enrollment and generate 85% job placements for our graduates. AmeriHealth Caritas DC is another valued partner. In recent years, AmeriHealth's Dr. Lavdina Orr served on our board of directors and helped guide our nutrition programs in the changing landscape of the pandemic and its aftermath. MedStar has also worked with our community outreach activities to provide health screenings and raise awareness of well patient vaccination services. DC Central Kitchen is just one frontline nonprofit organization working to address the unacceptable health disparities in our community. The fact that we have been able to cultivate relationships like these with DC's MCOs underscores, in our view, that community benefits are rightfully seen as priorities. Thank you for the opportunity to testify today, and I welcome any questions.
Thank you. Thank you so much to this panel of witnesses. I want to note that we've been joined by Councilmember Anita Bonds, who's an at-large member. Councilmember Bonds, we'll do 5-minute rounds for the public witnesses, if that's okay for you. Okay, great. All right. Ashley, if you could keep us all honest on the clock. But again, thank you to this panel of witnesses. I do want to ask a couple of follow-up questions. Mr. Gamble, you talked a lot, or you talked some in your testimony about system integration between healthcare finance, SSI, HSCSN, and the other entities. Is there another jurisdiction that does that better than we do? I don't like to reinvent the wheel, so if somebody else is doing it better.
That's something I'm not sure of, and mainly because I'm right now not clear exactly where the disconnect is happening in our system.
Okay.
From what I'm hearing from and this is from our medical legal partnership team, there are clients where they'll get a call or receive a letter from Social Security saying you have SSI, but then there's a delay in HSCSN being able to see that. And then kind of on the other end of the losing coverage part, it's like once they don't qualify for SSI, even though the child still has the same diagnosis that is all you need to qualify to continue with HSCSN, they're still being dropped. So I don't know with which entity, like what's happening in that disconnect. Mm-hmm. So because of that, I can't really compare to other jurisdictions of what.
Okay, so we kind of need to unpack what is the cause of why folks are being dropped. Got it. Okay. Ms. Jackson and Ms. Fallow, you guys have similar concerns. We're going to call them complaints. Concerns, which I think your concerns are completely valid. The idea that it would take over a year to go through the credentialing process seems a bit bewildering to me. Let me ask this. Ms. Fallow, because I think you probably have done this most recently. How different are the processes for credentialing between the 3 MCOs?
They're similar in certain ways, but they're definitely distinct processes. And I've done this both as initially for my group practice and then to bring other providers through. For some, it's digital. For some, it is filling out paperwork and emailing it to someone and then not hearing back and then following up. It's definitely different for each of the three. You have to manage each of them separately, including first getting credentialed through the district as well, which has its own pain points of technology and barriers there as well.
Yeah, I haven't been able to sort of determine what part of it is us and what part of it is the requirements of CMS in terms of making it so difficult. But to me, the idea that there is an MCO that is requiring actual physical paperwork as opposed to an online system where you can either, if you have documents that you need to upload, it's uploaded, but you're not emailing it to an unmanned email address.
Correct.
Okay. The other issues that you've raised, though, in terms of inconsistent coding for one of the MCOs, have you submitted a complaint about that?
Yes, and I submit appeals. For example, I've had one claim that was denied for saying that it was billed by another provider. I don't know who, I don't know why. I've appealed for it twice. I filed a complaint. That complaint is currently with a point of contact at the MCO that I follow up with on weekly and have had no resolution for since March.
Yeah, but you're running a business and you're having to check in weekly.
Yes.
On a claim.
Yes.
Let me
Google
ask
Snooze
this.
is my best friend.
Yeah. Ms. Jackson, how much money right now do you have outstanding and unpaid claims? You got to turn your mic on.
It's about $2,000.
$2,000. Okay. Ms. Fallow, how much is outstanding for your practice?
Probably around $4,500 to $5,000 unpaid.
Okay. I know for some people that doesn't sound like a lot of money, but because you're running a small business where it is a single, right? I think Ms. Jackson, it's just you, right? And
I also have a team.
you have a team, but still, margins are tight in the healthcare space. So Ms. Jackson, the team from WellPoint is here. Mr. WellPoint CEO, you want to raise your hand? There we go. Hopefully you guys can connect and there's somebody who can follow up on that side as well. Ms. Ballo, I'm not sure if you didn't name names and that's your prerogative, but if you want to name names, we can try to help you. You don't have to do it on the mic. You can see Ashley over here on my team, and we can try to help to get some of this resolved. As you guys know, I did the legislation for us to have doula coverage under Medicaid. And so, it's been 4 years at this point, and the fact that we still haven't worked out the kinks is a little frustrating. Actually, not a little, it's very frustrating because the maternal mortality crisis is still going on, and this was meant to address that. All right, I'm over my time. Thank you all so much for testifying. Hold on one second, because Councilmember Bonds might have some questions. Councilmember Bonds?
Thank you very much, Chairwoman. I really don't have questions. I'm very curious, though, about this whole arena of this disconnect that seems to be happening. I'm here as a chair of a committee that has our senior population in it. And so you know how strong we feel about that population, or we should be feeling about that population, because we all will be there if we're lucky and when we're lucky. So I'm concerned because they also are individuals that look after our young people. Grandparents are now taking care of a lot of our young folk who are in schools, et cetera. And so just wondered, we're talking dollars and cents today, which is right, but what about the anxiety that families must feel if they are having to wait for services? And is that something, an arena that you get involved in, or are you more concerned with being the connection between the provider and the individuals that receive the services? And for any member of the panel.
I'll jump in. Thank you for your question. So we're the intermediary between the services and the individual that's receiving them. We have found actually great success with our MCO providers, and that is because we've taken a lot of time to cultivate and build relationships with them outside of just the service side. As mentioned in my testimony, our MCOs also come down to our organization to volunteer their time and services so that they're also invested in what we're doing. And I think that's made a huge difference in when we make a phone call for services on behalf of a student that we serve, making sure that we get connected to the right individuals.
Anyone else?
From my perspective, and we don't deal with an elderly population specifically in our
Right.
demographic. However, I do work with a number of teen clients who are either facing pregnancy alone or facing a lack of support from other family members. And there is nothing more heartbreaking than turning somebody away because we cannot sustainably provide service and reliably get reimbursed for it. And I will say that I turn people away on a weekly basis, and it is painful.
Thank you. I'm curious about that. Yes. Yes, ma'am.
I would like to add that my hope is that providers and MCOs can have a stronger partnership in that middle ground. One of the families that I've had to turn away was from Community of Hope. And so the fact that an individual doula provider or provider team was requested from Community of Hope, which has their own set of doulas and services, expansive services, but yet they still sought my team out and I had to turn them away because I was not being compensated for my work that's ridiculous. So I would hope again that we could have a stronger partnership to fill in those gaps of our existing maternal health landscape, which is what we set out to do, right, with this,
Yes.
with this benefit. So
Yes.
for sure.
Thank you. So I guess today we're going to learn where the kinks are in the system and this rope that we're pulling from both ends so that we can straighten them out. Chairwoman is on the case, I can tell you, and so I'm expecting miracles.
Miracles. Okay.
Yes. Thank you very much to this
All
panel.
right, thanks to this panel. If you haven't given us your written testimony, please make sure you upload it for the record. Thank you so much. All right, we're gonna go to our next four. Maya Morris or Mia Morris. Okay. Charles Rosado. Charles. Terrell Peters. Dreaming out loud. Let's see, Terrell. Okay. James Sykes. All right. Tonya Blackwell. Well, we are just flying through this list. All right. Aaron Sabansky. Okay, Aaron's here. Patricia Quinn. She's here. And Mr. Lee. Okay. All right. Mr. Rosado, when you're ready.
Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Charles Rosado. I'm the Vice President of Network Operations at the DC Connected Care Network. I'm here to offer testimony on behalf of our network's 7 federally qualified health centers, including Community of Hope, who was just mentioned. As a clinically integrated network, we support health center attribution for over 121,000 DC Medicaid beneficiaries. When this network first embarked on the journey in 2024, our vision was bold but untested. We believe that by truly aligning DC federally qualified health centers, their integrated mental health services, and DC's community health partners around a common goal, high quality, high value patient care, we can not only survive but thrive in this evolving healthcare landscape. 2025 has been about turning that belief into action. Our foundation is built on 3 pillars: data, communication, and trust. The network's backbone is built on a spinal column of data and experience created by the DC Primary Care Association, which has supported DC health centers' maintenance of electronic health records since 2008. In partnership with district health information technology partners like CRISP, we now have a unified view of patient care, regardless of where care is delivered, breaking down the silos that have long fragmented the DC healthcare system. We've established the physician-led advisories, where various professionals sit at the same table, not just to support contract negotiation, value-based contracts in particular, but to design and administer care pathways for our shared patients centered on primary care. As you can imagine, complexity evolves throughout this journey as the network identifies and addresses challenges that impact the ability to prioritize primary care for addressing beneficiary healthcare needs. Value-based care results have started to emerge in Q3 of 2025. We are tracking measurable increases in preventative care screening activity across both pediatric and adult populations, as well as those with chronic disease. Our network is well positioned to support our health centers' increased focus on attribution and volatility within the Medicaid environment. We are delivering patient outreach campaigns and advancing care coordination design to educate DC Medicaid beneficiaries, to help reduce things like unnecessary emergency room department visits. These results are more than just metrics on a dashboard. They represent better health in the community and a more sustainable practice for our participating health centers and their staff. The defining moment of our first year was when we signed our first multi-year savings arrangement with WellPoint DC, formerly AmeriGroup. It outlines clear medical cost savings targets and contains a blended set of quality measures. The WellPoint contract signaled to the market that DC CCN is ready to become a true partner in healthcare transformation. It means we are accountable clinically and financially for the outcomes of beneficiaries we serve. It has sharpened our focus and accelerated collaboration in a way that fee-for-service driven reimbursement has not previously accomplished. This first year is proving our hypothesis: clinical integration and enhanced care coordination is the future. We've built this framework and we've begun the groundwork for a healthier community and stronger physician network.
Mr. Rosado.
I have time. As we end this first measure period while negotiating additional value-based arrangements, we look forward to sharing results. I'll pause for any questions or comments. Thank you.
Thank you. Sorry if I let you go on. Everybody else will add on after that. All right, Erin. Oh, if you just turn your mic on, set the button. There you go.
Good afternoon. I'm here to express my gratitude for my son Anthony's healthcare coverage through Health Services for Children with Special Needs, commonly known as HSCSN. While Anthony's care has been supplemented by HSCSN as his secondary insurer, it has covered his key needs, specifically his home health care and growth hormone therapy. We learned of HSCSN when Anthony was recovering from a brain injury at the Kennedy Krieger Institute. Anthony's brain injury impacted autonomic processes, including his respiratory drive and ability to swallow. The medical team explained to us that our son required a ventilator and 24-hour skilled nursing care to thrive at home. The social worker explained that our insurance only covered about 5 days a year of skilled nursing at home. Like most families, both my husband and I work full-time. We didn't know how we would manage. I'll never forget receiving the call informing us of Anthony's approval for HSCSN. I sobbed. After 6 months of living in hospitals, we went home on December 19th, 2012, just in time for the holidays. Without HSCSN, Anthony would have grown up in a long-term facility where the medical team was predetermined. By coming home, we were able to assemble a team of physicians and therapists across multiple institutes who shared our vision of providing the most normal and nurturing environment possible. Anthony still requires a ventilator and skilled nursing overnight, but we have successfully weaned him from daytime respiratory support and oxygen. He also learned to swallow, so we were able to remove his G-tube. To this day, specialists are astounded by how far he has come. The second significant impact that HSCSN has made in Anthony's well-being is the coverage of growth hormone therapy. By the time Anthony was 5 years old, he was not even on the growth curve, and he was shorter than my 2-year-old daughter. Our primary insurance plan impeded access to genetic testing. After publicly funded testing was inconclusive, they rejected the therapy because we did not have an approved condition for his stunted growth. Our HSCSN case manager helped us navigate the path to coverage of hormone therapy. And in the 9 years of administering shots every night, Anthony has grown 4 inches a year and is now in the 7th percentile for height. We have worked with most of the large insurance companies through the years. They are all the same in their tactics to delay, deflect, and deny bills. We do not have the financial resources or very much extra time to take legal actions to hold them accountable. HSCSN is different. We have a case manager who is familiar with Anthony's situation, who will return my messages on the same day and help me vet the task at hand. We are eternally grateful. When considering your budgeting priorities, please take Anthony's story and the other untold stories in the city into consideration and preserve this very special program. Thank you.
Thank you. Ms. Quinn.
Good afternoon. Patricia Quinn, Director of Policy at the DC Primary Care Association. I just want to say, Councilmember Henderson, really pleased to see you joining the class for leadership Greater Washington. Congratulations on that. I'm going to talk about two main issues that have surfaced for our health centers and DCPCA's recommended solutions to those billing issue challenges that our health centers have confronted. I appreciate you asking, is there somewhere else where they're doing this right? In both the case of credentialing, which is one of our issues, and third-party liability takebacks, we are recommending that the district adopt Maryland's process for both of those things. I'll share a little bit about what that looks like on our end. You know that we've been pursuing, we've made a request to DHCF for centralized credentialing. That request is still under review at DHCF. I think they have been exploring it carefully. Regardless of whether they move towards centralized credentialing, they could institute certain policies that we think would make a huge difference in the credentialing burden, which really is 5 separate processes that every health center provider must go through. You have already received from us the kind of what that policy looks like, but key to it, and I'll just share this one, written notice to providers within 10 days of submission of incomplete applications and steps to remediation. So when that credentialing request lands, the MCO reviews it within 10 days and either says, everything looks in order, you're provisionally credentialed, or everything is not in order and here's what you need to do to remedy that situation. We have some other details on that. I also want to recommend that for third-party liability, we look to Maryland for policies. In that policy, the MCOs are required to identify the other payer and to confirm that the other payer recognizes its obligation to pay the claim versus kind of putting all that burden to track down that payment and confirm it and to get it from the provider. If the identified payer does not acknowledge responsibility for the claim to the MCO in Maryland may not retroactively deny the health center claim or the provider claim. Community health centers are as is the entire health system, but particularly community health centers because of the changes that are heading our way in Medicaid. We need to make sure that payers pay in a timely and efficient way that does not require extreme burden on the provider end. Thank you.
Thank you. Mr. Lee. We got to turn on your mic. All right, go ahead.
God, Lord Jesus Christ, be with all these people who lost their life with this so-called coronavirus. May God, Lord Jesus Christ, be with 514-2001. Everybody call the Attorney General's office, the Department of Justice. So help me God. Everybody trying to be slick with public health and safety. Public safety, we are falling short. Now, the Secretary's office, Department of Health and Human Services, number 1. The Surgeon General's office, number 2. The Director's Office of the National Institute of Health, number 3. The Food and Drug Administration, number 4. The Center for Disease Control Prevention, number 5. The Public Health Service, and the President's Council on Physical Fitness Sports for the last 30 years. I live here too. I have a family too. It's very, very sad. And thank God, Robert Kennedy, all Bobby Kennedy has victory, the worst corporate criminals in almost every government agency. I've had this, Bobby Kennedy's son, the worst corporate criminal, pharmaceuticals in almost every government agency. Robert F. Kennedy, he's the Secretary of Health. And Dr. Fauci, this man, he's crooked, he's corrupt, he's a criminal. But 1619, Jamestown, Virginia, I've been clean for 40 years. 1619, Jamestown, you can't see through that. It's very, very sad. Leadership lost leadership. A beautiful, pathetic nation. A nation of the disgrace. And then you got people people misusing and abusing their position with the government. They're telling lies, writing bogus reports. Got your little hustle going. Got your little record. Everybody badmouth Trump, but you won't run or put together a team. Isn't that amazing? And, Mrs. Norton, been there for 30 years. Too many young people been killed on the streets. Too many have been wounded on the streets. Too many have gone to jail and prison. And too many haven't even finished high school. We have a committee on education, workforce, we have the Department of Education. For some reason, there's no committee on education. Exploiting the little children, the little girls and boys. We exploit each other. Very, very sad. And we must hold these scientists accountable. 40 years, no tobacco, no alcohol, no drugs, not one single drug. My report on law will be one of the best. My report on health will be one. I thank God. The worst corporate criminals, almost every government agency. It's amazing.
Thank you, Mr. Lee.
Thank you, Mrs. Henderson.
Thank you for your time. All right. Thank you so much to this panel of witnesses for your testimony. I do have a few follow-up questions. No. Sit down. Just wait. I do have some follow-up questions. Mr. Rosado, I wanted to ask, I know 3 minutes are not a lot of time to get all the things in, so I want to give you an opportunity to say more. You mentioned that as part of the value-based contract, you all are advancing care coordination design. Can you say more about what that looks like?
Sure. Thank you for the question. We know that our primary care entities, specifically our federally qualified health centers, are only seeing about 50% of the attributed population. We know that MCOs are responsible with organizations like WellPoint to attribute those members to a medical home, but it doesn't mean that the member is always coming in. Care is either reactive, acute, episodic. There's overutilization of ER sometimes due to patient education, not knowing what services are available through their primary care entity. And we've worked hard in both DCCCN and PCA on just addressing and improving patient trust and the relationship between patient and provider. We believe these are the reasons why that's happening, and we believe that a clinically integrated network can support getting these members into primary care, prioritizing and maintaining that care outside of a more expensive hospital setting.
Okay, you didn't actually answer my question, which was like, what does that look like day to day? You gave me a lot of high level, but like in terms of what is the work that the FQHCs are doing on care coordination? And the reason I'm asking is because we, as part of the Medicaid contract, are paying MCOs for care coordination. Are they passing that funding along to you all to now deploy that? Or that's what I'm trying to figure out, like, where does that come into play?
We do see infrastructure investment, and some of the services that CCN is advancing is text messaging, as an example, to patients, advising them of their care, driven around preventative screenings, lead for children, cervical cancer for adults, et cetera. Follow-up. Care coordination also involves navigating or helping the patient navigate through specialty care, hospital follow-up, including mental illness. They don't bring their medical records with them, which helps support that. So care coordination is the advancement of many things that the patient on their own is unable to achieve.
Okay. Ms. Quinn, I'll bring you in on this conversation. So as part of the pre-hearing questions that we sent to all the MCOs, we asked a question, how many of your enrollees have had no claims in the last 36 months? So that's like, you haven't been to a pharmacy, you haven't been to an ER, you haven't been to the dentist in 36 months. And, you know, I've got one MCO, they've got 16,000 people, 36 months. Now I'm paying per member per month for 16,000 people not to go to the doctor. Another MCO, 15,600 folks. Now one MCO didn't actually answer the question as we wrote it, but that's okay. But nonetheless, they also have thousands of people as well. So it seems to me that this is like a problem beyond just care coordination. Because there's a couple of things that can happen.
Yeah.
Either one, the person does not exist. You've moved out of the jurisdiction and we have been passively renewing you, but paying for you not to use. Two, you're incredibly healthy. Healthy as a whistle. Or three, you're out here suffering. When in fact, you could be receiving care. But how do we get to these folks? And I don't know if a text message is really gonna move the needle when we're talking about 15,000 people who haven't sought care in 36 months.
Yeah, to a point, this is going to become a very relationship-based effort. You know, finding the people who can find the people is going to be really important to understand from all of those 16,000 patients in that one MCO, what are the buckets? Like who really needs to be off the rolls? Who has not really needed care? I would say from a primary care perspective, we want people coming into primary care regardless. So it's not about just, are you ill? And that's been our main challenge with health in our health system in general, that it is about sick care and we utilize it like sick care. So part of what the CCN is going to be able to do by marshaling collective resources is create an environment where people begin to understand and utilize primary care in the way it was intended. Primary care as the quarterback of care, regardless of whether you have chronic disease or you're just coming in for preventive care. So some of it is going to be boots on the ground, using some of the infrastructure dollars to create the force that can go and find people who need to be brought into care. And support utilization of primary care in the way that it was intended.
Okay, Councilmember Vance, I'm over my time. I do have a couple other questions. Okay. Let me switch gears really quickly in terms of the credentialing third party take back. We'll take a look at Maryland. I feel like we've been talking to healthcare finance about the credentialing issues for a little bit longer than I want to admit. And just for folks like, this will tell you, we have a bill. We haven't used it because I try not to have to do everything from legislation, but we do have it if it exists, because I think the last time we talked to healthcare finance about this was during the budget process where they told us like they're actively looking at it, which now I'm knowing actively looking means I'll check in the next time that you ask me about it, but I'm not going to necessarily actively offer a solution on that front. I think where we are in credentialing is the same place as sort of where we are when I have DC Health in front of me and we're talking about professional licensing. I do not understand why in a time where we need people, we need a healthcare workforce, we need providers who are coming into the system. We want providers who want to accept Medicaid patients because we know that we've got so many who are opting out for reimbursement rates and otherwise. How we can dangle someone, a provider, along for a year and a half, it does not make sense. And also how the credentialing processes for all three of our companies are so substantially different, even though I'm sure you're asking for the same information, but you might just be asking for it with a different sentence.
So the billing system, we meet literally every Thursday morning with our FQHC billing and finance teams to try to address a range of different issues in the MCO billing system. Credentialing and third-party liability are the biggest buckets that we think we have a solution. In terms of where DHCF is, I'm with you. We don't come to you first, you know, we're always going to go to the agency first. And in fact, on the credentialing issue, after we approached DHCF, we approached all the MCOs and said, you know, DHCF is reviewing this, but you could voluntarily look at these
Come together.
and perhaps adopt some of our recommendations. And I still think there's opportunity for that. You know, if we don't need a hammer, you know, it can be like, how do we make this work in a more efficient way? Because we do have providers who are coming into FQHCs and are unable to bill 4 months. And that's incredibly difficult in this fiscal environment for health centers. It becomes an access issue.
Yeah.
You know, for
And network adequacy issue too, right? We've definitely had that in terms of pediatric dental in the Medicaid space, and certainly on behavioral health as well. But
I think we have a good solution.
yes, I mean, I'm just saying, like, if I'm a private provider providing a service where I know I can make more money using just private insurance, no insurance, right, in the behavioral health space, why would I even go through the time to deal with any of the MCOs if it's going to take me, you know, a year to do it, and then like one of the providers, I got to call you every week to chase you for money? I would just say, I'm good, which is what we're seeing happening, right? Okay.
I just lost my primary care provider to a concierge practice, you know, so there's all kinds of movement away from the primary care that we know if we get primary care right, we can that's health equity. That's where health equity happens, in primary care. I think the MCOs, you know, being here today, I think we have shared goals on many things. So I feel like we can come together and solve some of these problems.
Okay. Ms. Sabansky, thank you so much for being here and sharing your story in terms of the work of HSCSN. They're incredible stories in terms of the young people and the families that they serve. The good stories don't always make it to us, so it's always good to hear for those who are satisfied. So thank you, Mr. Lee. Councilmember Bonds.
Thank you very much, and thanks to this panel. I do have a few questions. I'd like to know from the Connected Care Network, when you talk about your clinical care coordination, this program, how many service providers participate in this program?
Thank you for the question. All 7 of the federally qualified health centers, I believe the only FQHC inside of DC that we do not have part of the Connected Care Network is Elaine Ellis. But the larger organizations, including Unity, Mary's, Community Hope, Whitman Walker, and others, are all part of that process. Our responsibility is to negotiate the value-based contracts as well as execute in advanced areas like care coordination. It allows all of the participating health centers to opt in, and all 7 of our federally qualified health centers did opt into our first agreement earlier this year.
Okay, tell me a little bit about how they track their clients. Are you talking with them about how they track their clients? Because I'm trying to get back to this 16,000 and we're paying for, and want to know what we're paying for.
I think it's unfortunate to report, Councilperson Bonds, that oftentimes when the patient leaves episodic care, the patient does run the risk of being lost in the wind, so to speak. We are pushing for follow-up activity, for example, annual wellness visit and reoccurring screenings in the various pediatric adult categories. Having the right contact information to get a hold of the patient is a challenge. And then, of course, the resources that the clinics are providing, the limited resources the clinics are providing for those that have established care and are repeat and regular users of the federally qualified health centers, it becomes a different narrative to then what does it take to go get that patient back who's not utilizing those primary care services. We see those two conversations separate.
You know, I think that traditionally, all of us understand that healthcare is a business, but it is more than that to us human beings. And as such, I'm very curious as to how we treat others, and ourselves, our families, as it relates to providing service. For instance, is there a mantra within the organization that you are talking to these 7 providers that it's important to either offer or to make sure that everyone knows they need to maybe have an annual checkup? How do we, what is it that we expect of the provider as it relates to the community? Because I feel like there's a disconnect. I feel like everything is about that thing called, S with the lines through it, dollars.
I think there's a tremendous degree of compassion and focus on empathetic care, not only in the connected care network, which is really an administrative angle of the health centers, but the health centers themselves. I think that we've heard countless stories of how high quality service for the patients that come in and what they can expect to receive. Wraparound services, not just getting their medical, but their dental, mental health integration, right? Whole person care. I think our providers do the very best job that they can with their patients of encouraging those follow-ups and those, next step visits. I think the challenging part are the patients that don't walk in through those doors, the patients that prefer or prioritize emergency room care, and that's exactly what we're trying to change.
I hear you. And Ms. Quinn, what do you think about what is the responsibility of, I'll say, you sit as big brother up here and you've got providers here. What's the connection to those of us who are just the people? How should we feel that the organization should treat us, to remind us, to get us in? Because sounds like we don't have a tracking system, but we have a money system. That's what I'm concerned about.
Well, I'll say, excuse me, we have access to a lot of data about patients, those that we see and those that are attributed to FQHCs. So a big part of what the CCN is working to build is how do you utilize all that information for action that supports patient outcomes? And that's a huge part of the work that Charles and his team are doing. I think the FQHCs start from that very same place that you're describing. People who go into primary care, number 1, and primary care at a federally qualified health center, number 2, are coming to that work with a passion for connecting to individual patients who maybe have not received that kind of person-centered, high-quality care in other settings where they've come. And so we take a lot of pride in that is, we are mission-driven to provide that kind of care. One of the good things about the health centers coming together in the way that they have, which is unique, this is the first time that they have come together to target some of the things that you're describing, some of the challenges that maybe as individual health centers, getting that message out about what is primary care, what's it for, and what does it mean? Why do you want to have that kind of connection to a primary care provider? Having a collective voice to build that message, market primary care specifically and health centers particularly, is going to be part of the work of the Connected Care Network. Because if you have a good primary care doc, a lot changes in your experience of care. And somebody who's really tracking and accompanying you through the health system, which is, I think, what you're describing, like what happens to people on the ground who need that support, families who need that kind of support. We're at the early stages with the network, but I think we'll be able to share a lot more in the coming year.
And that's great, and I appreciate that, but I'm thinking we should also think about how we write into the contracts, the agreements that we have with organizations that they're going to do that work, because we do not have a penny to waste.
Right with you. We had sent a letter a year or so ago, Charles, to DHCF about what were some things they could do within the MCO contract language that could enhance the ability to provide this kind of very person-centered, value-based care. The Connected Care Network is on the team of wanting to make sure that any kind of care someone gets from an FQHC is the district is getting its money's worth for that. And there are some language things that we've recommended.
All right. Well, thank you. Thank you, Chairwoman.
Thank you.
Thank you.
Well, thank you to this panel of witnesses. I don't have any further questions. So just make sure you provide your written testimony for the record. Thank you. All right, the last in-person witness that I have on my witness list is Dr. Chapman. Is there someone else who had signed up to testify? You thought that you were going to be testifying in person, but I haven't called your name. Going once. Going twice. Okay. Is there anyone in person who you find yourself on the virtual list? All right, Dr. Chapman, you've got the table to yourself.
Does that mean I get more time?
That does not, but I thought you might ask though. Go ahead.
I actually had invited one of my patients here who had overdosed in the office 12 days ago. I've been practicing medicine in Washington for over 50 years. I've been on Benning Road Northeast. It's been in the news for 45 years. So I've seen just about everything. About 2 years ago, we noticed a marked change in the billing system. I participated with all three of the Medicaid MCOs, but each one of them had their own mechanism for billing and services. I treat the opioid population. So 95% of my patients now are opioid addicted, which means that it comes with a plethora of problems, including mental health problems, social determinants of health, housing, homelessness, et cetera. But 2 years ago, one of the MCOs stopped paying, and my biller called me in November of 2023, the very peak year of the overdose epidemic. And we found out that they would not pay for the top code for us, which is 99215. So there are 5 codes. That's the top code. Everybody that comes in tests positive for fentanyl and maybe a bunch of other drugs. So we went almost a year before we were able to talk to the mental health medical director for that plan. And they immediately turned to the AMA coding manual, which is a bit complex for us. But we had the down code, and I've given talks all over the country about down coding. I didn't really know what down coding was, and I didn't know that the AMA actually had a policy written in 2022 talking about down coding. So it's a mechanism for paying less, simply, for very complex patients. Meantime, I got audited by one of the other 3 Medicaid MCOs, and they continued to pay me just as I had been getting paid for these patients. And then the third MCO actually retroactively took money back for 2023. So we obviously have protested that whole process. I was actually offered a contract by the SOAR director, the state opioid response director, Sharon Hunt, to train providers to treat this population. And I told her that I needed 2 things. One, I needed a common treatment model, and the second, a common billing model. It took us 10 years to get buprenorphine, one of the 3 FDA-approved drugs, to the dosing level that we had told them that we needed in 2015 to treat fentanyl. So the FDA, as of December the 26th, 2024, changed the guidelines based on the work that we did with Howard University College of Pharmacy and published 2 previous papers, but it took 10 years to get that. So we're now facing a situation where down coding, and I think you'll hear more about that from the president of the Medical Society of DC, is the new mechanism, just like PBM changing medications was another scheme that the insurance companies used. This is the latest, and it's very difficult to get providers to treat these high-risk patients unless they are successful and have the knowledge, and if they get paid for taking that risk. So any day, we have 2 or 3 patients a year that will come in the office and down and overdose. It took 8 Narcan, and that patient never woke up. The EMTs got there, and they gave him an injection of Narcan, and he jumped straight up. So I told the patient, we made a deal. He came back to the office for his regular buprenorphine dose a week ago, that I would order injectable buprenorphine that would last a month. He came in yesterday and he refused to take the shot. So he's still on the sublingual. He's still testing positive for fentanyl and cocaine, but this is what we go through. It's tough not getting paid. I couldn't pay myself for the first 3 months of this year because I didn't get paid by the MCOs.
Okay, Dr. Chapman, I gave you some of my time.
Okay.
Respect. So this is just a couple of follow-up questions. When you finally got a chance to talk to the behavioral health medical director of that MCO, what was the reasoning provided for the downcoding?
They followed the what was supposed to be the AMA guidelines. You had to have 2 of something or whatever. It just never made sense. You have to remember, I've been billing for in a private office for 45 years and never had anybody take any money back. Let me tell you what happened.
Because again, you were borrowing on my time. I'm just trying to get to some of the more systematic issues, because I don't know if yours is fairly unique, or are you hearing a similar complaint happening with other behavioral health providers who serve populations such as yourself?
I don't know if it's other behavioral health providers, but the Medical Society has identified the fact that downcoding is now an issue.
Okay, so across the board. All right. Let's go back to the fact that you are still waiting on payment. How much in outstanding claims are pending right now for your practice?
So what we did, we just went back and for that whole year and submitted the lower code, and they subsequently paid incrementally. So we did get paid, but we got paid at a lower code, which means that our income dropped about 20 to 25%. Because of that. And then when the second company took $13,000 back from 2023, the peak year, and I look back, they had actually sent me audited information that indicated that I wrote 90% of the buprenorphine prescriptions for that company. I had 71 patients, and I think combined, all the other providers had about 8 patients. So, I was on the opioid abatement committee with you and with Patricia Quinn and the Attorney General. So we filed a complaint with the Attorney General's office, and we're investigating it in detail because I can explain in detail exactly what happened.
Okay. All right. I don't have any other questions, Councilmember Bonds.
Thank you very much, Dr. Chapman, for being here. Always, I read what you send us all the time, so thank
No,
you
you
so
don't.
much. I do read it. Yes, and sometimes it's 6 pages, but I read it. Thank you very much, and thank you for your practice. I regret that you have so many customers, but someone has to do it, and you're willing to do it, so thank you very much.
So there's one hump that you do because you have to. The second hump is the one you do because you want to. This is critical to our community. I've seen too many people die and die needlessly. And, I'll be 80 years old next year, but I'm having the best time of my life. As a matter of fact, the Howard University College of Pharmacy just got a grant from the Department of Behavioral Health. It's a tracking system that's been implemented in the state of New York. So we're going to get that tracking system here, and I think it's going to make a difference, not just for opioids, but for some other chronic diseases where patients are having a difficult time, and we're having a difficult time keeping up with them.
I appreciate hearing and learning that that will help us. I too believe there are too many problems in the health arena, and we just haven't given the attention to it like we do to many other things. When I see that Amazon tracks the movement of all of their staff from the time that they're on duty to the time that they leave, and I wonder, my goodness, why aren't we doing that for so many needs that we have without it being considered Big Brother staring down on you? But thank you for putting that information in the airways. Thank you very much.
Thank you.
Thank
Thank you. Thank you so much. Okay, so we're going to go to virtual witnesses. So for the virtual folks who are standing by, we're going to do panels of 7. You do have to affirmatively accept our invitation to become a panelist. And so you'll see a little button that pops up. So there were a couple of people who were signed up for in-person who are now virtual. Maya Morris, Crystalith Kirantes, Umar Mohammed, Doc Winston, Mark Lavoda, Dr. Clint Peoples, and Tracy Event. Okay, we're going to also do Bernice Anderson. Okay, Ms. Morris, when you're ready.
Good afternoon, Councilmember Christina Henderson and esteemed members of the Committee on Health. My name is Maya Morris, and I serve as the Director of Resident Services at Jubilee Housing here in Washington, D.C. Thank you so much for the opportunity to be here today, and I wanted to testify regarding our partnership with WellPoint DC and why it matters so deeply to the residents that we serve. At Jubilee Housing, our mission is to provide safe, affordable housing paired with comprehensive support services that empower residents to live dignified and independent lives. We currently operate 13 buildings and annually serve over 1,000 residents in the Adams Morgan, Mount Pleasant, and Columbia Heights communities of Ward 1. And we also provide wraparound services for youth, seniors, families, returning citizens through a model called Justice Housing, affordable housing, and resource-rich neighborhoods. Our relationship with WellPoint DC began about 4 years ago when they were still operating under the AmeriGroup name. At that time, we were struggling with low vaccination rates amongst our residents. Instead of just flagging the problem, WellPoint DC reached out to us directly, which led us to hosting vaccination clinics on site and learning how essential an access point affordable housing can be for health-related initiatives. It set the stage for the way we have worked together ever since. From that first moment, WellPoint DC, they've just been consistently showing up on the community level. They've joined us for National Night Out to strengthen our neighborhood safety. They've attended our wellness fairs, back to school events, supporting cultural events like our Black History and Hispanic Heritage Month celebrations. They've just been really hands-on and fully present. They're also hosting a housing and health panel in November for the Washington Business Journal, where they're going to be lifting the message that safe, affordable housing is directly tied to health. Thanks to our partnership, I'll actually be representing Jubilee Housing on the panel for this event. What sets WellPoint DC apart is that they don't just fund or sponsor from a distance. They keep us informed. They send representatives to engage with our residents directly. They take the time to listen. Their commitment to support our housing stability, health and wellness, and youth and reentry services reflects a deep understanding that health is about more than a doctor's visit. It is about the social conditions people live in every day. Healthcare and housing are two of the most important social determinants of health. When they are brought together, the results are transformative. We're really grateful for WellPoint DC's commitment and believe their approach can serve as a model for how managed care organizations and mission-driven housing providers can work side by side. Partnerships like this give us a glimpse of what is possible when we keep health equity and community at the center. Thank you so much for the opportunity to testify today, and I welcome any questions.
Thank you. Hold on one second. Okay, Cece?
Good afternoon, Chair Henderson and Councilmember Bonds. I appreciate the opportunities to address you all today. My name is Chrysanthi Corniotis, better known as Commissioner Cece, and I am a DC resident, a health policy professional, a former ANC commissioner in Ward 4, and most importantly, the mother of a wonderful daughter with a rare genetic condition and other related health needs. I am here today to speak about the critical importance of healthcare access for children with special needs. And I would just want to highlight just very quickly how my daughter, I know in my heart, would not be here today without the support of HSCSN. And the urgent need for caregiver reimbursement and respite care in the District of Columbia. Raising a child with complex medical needs is a profound joy, but it is also an extraordinary responsibility, which I have taken seriously from the first day that my daughter came into my home as a foster baby at 6 months old after having life-saving heart surgery. Families like mine are often managing multiple specialists, therapies, medications, and equipment, while also navigating insurance rules and public benefits. This is a second full-time job layered on top of employment, household responsibilities, and most importantly, being a parent. Too often, caregivers shoulder this work without compensation, even though it directly substitutes for professional care. For example, when I spend hours each week managing my daughter's schedule, coordinating appointments, or providing outside therapies, I am performing the kind of work that would otherwise require trained providers. Yet, unlike those providers, family caregivers are rarely recognized or reimbursed. This is not only undervalues the work we do, it places tremendous financial stress on families already under strain. Respite care is equally critical. Caregivers need time to rest, restore, and simply be human, so we can continue providing safe and effective care to our loved ones. Without respite, families burn out. In the worst cases, children may end up in institutional settings, not because their needs can't be met at home, but because their caregivers are exhausted and unsupported. Investing in respite is not just the compassionate thing to do, it is the cost-effective thing to do. Keeping children at home with their families is far less expensive than institutional care. I urge the council to consider policies that, one, expand caregiver reimbursement programs so parents and family members can be compensated for the skilled care they provide. Two, fund and scale respite care services to give families the relief they need to sustain caregiving over the long term. And three, streamline access to specialized healthcare for children with rare and complex conditions, ensuring equitable support across all DC communities. Families like mine want what all families want, for our children to be healthy, safe, and able to thrive. With thoughtful investments in caregiver reimbursement and respite care, DC can be a national leader in supporting children with special needs and the families who love and care for them. Thank you for your time and for your commitment to this issue. I am happy to answer any questions.
Thank you. Mr. Mohammed. Oh, Mr. Mohammed, you're on mute.
I'm sorry, Councilmember Henderson. Good afternoon, Councilmember Henderson and members of the Committee on Health. My name is Saquon Umar Muhammad, and I work as the Outreach and Engagement Specialist for Dream Out Loud. We appreciate the opportunity to testify before the Committee on Health regarding the operations and impact of managed care organizations in the district's Medicaid program. I'm here to speak about our partner, WellPoint DC. Dreaming Out Loud is dedicated to advancing health, wellness, and equitable access to nutritious food for all Washingtonians. Through our place-based initiatives such as the Farmers Market at Kelly Miller and the new Marenbury Avenue Market and Cafe, we work to create meaningful opportunities for residents to make healthier choices and build stronger community connections. WellPoint DC has been a longstanding partner with Dreaming Out Loud, supporting our work through funding, volunteer participation, with collaborative programming coming soon. Their contributions have directly supported the success of our annual events, Spring Fest and Fall Fest, in addition to the Farmers Market at Kelly Miller and other community health initiatives, enabling us to reach more residents, provide nutritious food, and engage community members in health and wellness education. Excuse me. This partnership exemplifies, this partnership exemplifies the positive outcomes that can be achieved when MCOs collaborate with local organizations to promote preventive care, healthy lifestyles, and community well-being. We recognize the committee's focus on network adequacy, patient access, value-based care, care coordination, and reducing health disparities. Our collaboration with WellPoint DC aligns directly with these goals. One, network adequacy and access. By supporting community-based programs, WellPoint DC helps connect Medicaid enrollees to local resources that improve access to healthy foods and wellness services. Two, care coordination, and value-based care. Through joint initiatives, we plan to ensure that their members receive preventive education and support that complements their clinical care, addressing social determinants of health. Three, reducing health disparities, targeting efforts in historically underserved communities east of the river, helping to bridge gaps in nutrition, health education, and engagement with healthcare services. We are grateful for WellPoint DC's commitment to supporting initiatives that strengthen the health and wellness of all Washingtonians. Their engagement with Dreaming Out Loud provides a model for how MCOs can collaborate with community organizations to deliver measurable, meaningful outcomes. Thank you for your attention, and we look forward to continuing to work with the committee, WellPoint DC, and other partners to advance the health of our District of Columbia. Thank you on behalf of Dreaming Out Loud.
Thank you. Dr. Winston?
Thank you. Good afternoon. I am testifying on behalf of the Medical Society of the District of Columbia, the voice of more than 11,000 licensed physicians caring for patients across the district. Every day, our physicians see how Medicaid makes the difference between patients receiving timely, life-saving care and patients falling through the cracks. The strength of DC's Medicaid program is not an abstract policy matter. It is a matter of health, dignity, and lives. A strong, viable Medicaid program with a diverse provider network is essential to a healthy DC. Yet today, this safety net is under threat. MSDC stands shoulder to shoulder with the healthcare community in defending Medicaid and ensuring it continues to work for patients. As cost pressures mount for the federal government, managed care organizations must not respond by making care harder to access. One troubling practice we are watching closely is downcoding. Recently, Cigna announced it would automatically downcode evaluation and manage claims without first reviewing medical records. This means that a complex patient care visit could be incorrectly reimbursed as simple ones. Downcoding is not just a billing tactic, it is a barrier to care. It forces physicians to spend hours appealing denials instead of seeing patients. It destabilizes independent practices that already operate on thin margins. And most importantly, it harms patients who risk losing access to thorough, comprehensive visits. Consider the patient with diabetes and hypertension and depression who needs a longer, more complex visit. If that visit is automatically downgraded to a simple level, the physician is penalized for providing careful, high-quality care. Over time, this erodes access in entire neighborhoods. While DC MCOs have not publicly announced mandatory downcoding yet, we know this practice is spreading nationally, both formally and informally, and we are hearing troubling stories from local physicians of local downcoding. MSDC is therefore working to introduce legislation that will prevent downcoding without an appropriate review. Our goal is simple: protect patients and preserve the integrity of care in the district. Attached to my testimony is an AMA guide to downcoding that explains the issue in greater detail. And the bottom line is this: Medicaid should be a lifeline for patients, not a loophole for profit. The District of Columbia's physicians are committed to caring for every patient who walks through our doors. Thank you for the opportunity to testify. I welcome your questions.
Thank you. Mr. Lavota.
Thank you. Chairperson Henderson and members of the council, thank you for the opportunity to testify today. My name is Mark Lavota. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole person care for district residents with mental illnesses, substance use disorders, or both, including the 35,000 district residents our 35-member organization serve annually. The district's Medicaid managed care plans have a tremendous impact on the well-being of district residents, with responsibility for access to health care and payment for treatment for 2 of every 5 residents. Managed care program performance could be strengthened in 4 critical ways. First, the district should be more aggressive in its selection of goals and targets in the managed care quality strategy and hold plans accountable for poor performance. Second, the district should make better use of the review process and the findings from the third-party external quality review organization and its annual technical reports. Third, the district needs to reinstate managed care plan level pay for performance, both for its own merits and as the linchpin toward effective deployment of Medicaid provider level value-based payment. Fourth, the district should recommit to managed care behavioral health integration by unpausing the carve-in of services delivered by the Department of Behavioral Health Provider Network. Managed care plan accountability is directly tied to plan contracts with the district government, but the district misses significant opportunities by making insufficient use of contractual requirements for plans to comply with the district's managed care quality strategy. The council should ask DHCF for an update on 2025 targets. Among provider concerns during the 2024 update, DHCF did not set goals and objectives regarding timely processing of UMUR determinations or timely processing for credentialing. Individual plan accountability would be strengthened if DHCF had stronger expectations for the overall managed care program through a stronger managed care quality strategy. As the council explores managed care performance, the council should make special note of the annual technical reports delivered by the independent EQRO selected each year to review managed care performance. Review of EQRO reports from before, during, and following the COVID public health emergency show persistent performance deficits by all plans across some consistent domains. Areas that the ATR shows are deficiencies across all managed care plans should be addressed each year in the council's DHCF oversight to determine any course correction DHCF needs to make. Managed care plan accountability for high expenditures and unnecessary use of higher levels of care was more successful when DHCF used pay for performance provisions of its contracts with managed care plan carriers. Unless plan level pay for performance is reinstated, district is not likely to see meaningful progress on provider level value-based payments. The district's managed care program would also be stronger if behavioral health was fully integrated. The so-called pause to the previously planned carve-in will need to be lifted if we want plans that are responsible for people's physical health needs to be able to address the behavioral health conditions not being treated adequately. DHCF, along with the Department of Behavioral Health this fall, is moving behavioral health UMUR to DHCF's contracted co-imagine. Managed care plans would be a superior option. We should move in that direction with the lessons learned from the co-imagine transition. Thank you for the opportunity to testify today. I look forward to answering any questions you might have.
Thank you. Dr. Peoples.
Thank you, Chair Henderson. Appreciate your time today. My name is Dr. Clint Peebles. I'm chair of the Medical Society of DC's Advocacy Committee, as well as president-elect designate for MSDC in 2026. While Dr. Winston is testifying on behalf of MSDC, specifically highlighting downcoding practices, which we're very passionate about right now, I wanted to testify today to emphasize the importance of ensuring compliance with the prior authorization reform law passed and funded with your leadership. I know there were concerns in the payer community about some aspects of the law, but I want to emphasize the importance of the MCOs in complying with and reporting on specific aspects of the law. Every day, physicians in the district see treatment interruptions, medication denials, and burdensome appeals. These delays not only worsen health outcomes, but also deepen inequities, and this is why strong oversight is essential. In particular, I want to commend your committee for asking for metrics on length of determinations. It was only a few years ago in 2019 that AmeriHealth had a 20% denial rate on prior authorization requests, and I look forward to your committee receiving responses on the turnaround time on prior authorization requests and suggest asking for further data on primary reasons for denials beyond the usual catch-all of inadequate paperwork. To build on this, I respectfully urge the committee to require standardized reporting of denial rates, turnaround times, and appeal outcomes, as well as transparency on reviewer credentials, including licensure, location, and specialty. Additionally, we would be interested in the committee exploring not just the network adequacy for patients, but also for providers. Reviews must be conducted by physicians licensed in the tri-state area and in the same or similar specialty as the treating clinician as required by law. Ensuring this provision is followed is essential to both patient fairness and provider confidence. Because of the negative effects a denial has on patients, it is important to have statistics on who is reviewing these requests. The Prior Authorization Reform Amendment Act was an achievement to help provide equitable care to residents of the districts, but without vigilant oversight, its promise risks being undermined. On behalf of our patients and the physicians who serve them, I urge this committee to continue demanding accountability and transparency from the MCOs, and thank you so much for your leadership and for the opportunity to testify today. Thank you.
Thank you. Tracy at Vent. Oh, Tracy's not here. Bernice Anderson. Okay. That's all for this panel. All right. Thank you so much to this panel of witnesses for testifying. I just want to get a couple of follow-up questions really quickly. Dr. Peoples, in terms of the concerns around compliance with prior authorization, is it what you're seeing specifically as it relates to the Medicaid MCOs, or is it more with the private insurance practice?
So it's a great question. Thank you. We're certainly seeing it with both. I'm seeing it more personally in the private payers, but we do have reports of this happening in Medicaid as well. And if you need more specific data on that, I'm happy to work on getting that to you.
Yeah, that would be good in terms of our ability to follow up on that. We did receive some data around prior authorization in preparation for this hearing. But I think it is a little not outdated, but we certainly don't have the information for calendar year 24. And so I'd be interested to kind of see where that is. And also, as the medical society knows, trying to implement the prior authorization law and have it also apply to Medicaid was an area where we got pushback. So I do want to sort of touch base on these things because what we didn't want to have happen was a bifurcated system whereby if you have private insurance, your insurance company is required to respond to the prior authorization request in a quicker turnaround than if you have Medicaid, even though you might have the same urgent request and or condition.
Correct.
Dr. Winston, I guess I'll take this opportunity to say thank you for your services for your year as president of MSDC, and I appreciate you coming in to sort of testify. I think MSDC is coming in. I have a meeting with the organization in a little bit, I think for a lobby day, but I would love to talk more about down coding in that conversation so we can get a bit more in depth, perhaps way more than what we can do here in this hearing. So thank you guys for being here. Mr. Lavoda, always good to see you. And, you raised some of the very similar concerns and challenges others have brought up in terms of what does the future of the behavioral health carbon look like? I don't have an answer for that, and healthcare finance isn't here today. But that's something that we're continuing to sort of work on as well, especially since we know that so many providers put in so much work on the front end only for it to be paused at what seemed like the 11th hour in terms of that work. So we'll keep looking at that. I don't have any specific questions further for this particular panel. And Councilmember Bonds did have to go. So thank you to everyone who testified. Please make sure you submit your testimony for the record. Okay, we're gonna go to our next panel. Vandella Williams, Gail Event, Keontae Burns, Marquette Jones, Joanne McCrae, Melissa Copolau, Xenia Sanchez Fuentes. Oh, okay, I will keep going. Kurt Gallagher, Thomas Cunningham, Albert Coombs, Ann DiGirolamo, apologies in advance, and I think Jimmy Williams. Now I've called the whole list. Okay, let's see. All right, Miss Williams is not here. Miss Event is not here. Keontae, not here. Marquette, not here. Joanne, not here. Melissa's here. Melissa, when you're ready.
Well, thank you. Okay. My name is Melissa Coppolo. I have been a proud DC resident for nearly 25 years, and I would like to thank you for affording me this opportunity to honestly finally have a public space to address my experience with HSCSN. I cannot say enough good things about HSCSN. My now 13-year-old twins were born quite unexpectedly when I was barely 25 weeks pregnant. My son weighed in at 1 pound 14, while his twin sister barely tipped the scales at 1 pound 3 ounces, which is barely more than 4 sticks of butter. My son's time with the NICU was fairly uneventful. He just needed extra time to cook, as we like to joke. But my daughter's time was a roller coaster with far, far too many life or death moments. I was given little guidance or advice from the hospital social worker over the course of the 113 days in the NICU, other than to apply for SSI. I did not realize at the time that this would be life-changing advice. After both children were home for a few months, we received a flyer under our door, and it was a flyer for us to apply for HSCSN. When I called the number listed, I remember being shocked that the organization took the effort to come find us. In the hell that was the first years of my children's lives, I would not have had the mental space to even look for support. As with the social worker's advice while in the NICU, this flyer was a lifeline. While I'm speaking about my personal experience with HSCSN, I feel confident that I'm speaking on behalf of all parents and caregivers of medically complex children when I say that I cannot imagine what life would be like today without their support. And yes, I say their support and not its support, because in the more than 12 years we have benefited from HSCSN medical coverage for my daughter, I have never met a single person that did not go above and beyond, who did not see me and my daughter as individuals, and who did not treat us with grace and dignity, which is often overlooked. Dr. Eric Levy, the Chief Medical Officer of HSCSN, replies to each and every email I've ever sent him, usually within hours. He has never dismissed my questions, almost always handling my concerns personally. The case managers we have assigned over the years, every single one has been the best of humanity. Knowing that I always prefer in-person check-ins, our current case manager, India Ford, always makes time in her schedule to come to our home and connect with us. Years ago, when we outgrew our 2-bedroom apartment, we looked to move to Maryland or Virginia. There was only one reason we chose to stay in the district, and that is HSCSN. HSCSN is absolutely unique to DC, and families like mine rely on its service. Without it, we would not be able to remain here. My daughter has had 15 brain surgeries, 1 spinal cord surgery, a cumulative 1 year in the hospital, and still receives weekly PT, OT, speech, and vision services. Without HSCSN, not only would she not be thriving today, the financial and emotional cost to my family and the District of Columbia would have been devastating. HSCSN is not just a life-changing experience, it is life-saving. Before I close, I would also like to single out Colleen Sanoski, the Associate Director of Division of Children's Health Services in DC's Department of Healthcare Finance, who administers this program. She too was an absolute gem of a human being, always responsive, always understanding, and again, always treating me and my daughter with dignity. Council members, please continue to fund, protect, and strengthen HSCSN. Families like mine depend on it, and this district is stronger because of it. Thank you for your time and attention, and thank you for HSCSN.
Thank you. Vinya? Ms. Sanchez Fuentes.
Hi, good afternoon. My name is Xenia Sanchez. I'm a partner at Terrace Pradlick and Million, a public interest law firm. We represent the plaintiff class of over 100,000 Medicaid eligible children in the District of Columbia in a class action lawsuit brought in 1993 against the District of Columbia, Salazar versus the District of Columbia, regarding violations of the Medicaid statute, which has resulted in a settlement order against the District of Columbia. Now, under this settlement order, we provide legal assistance to individual class members when Medicaid services are being delayed, denied, suspended, or terminated. A large portion of the assistance that our firm provides to individuals is to families with children with special needs, most of whom are enrolled with the smallest of the district's Medicaid managed care plans, health services for children with special needs, and to a lesser extent, other managed care plans. The Department of Healthcare Finance has set a timely access standard of 30 days for managed care plans to provide medically necessary services to children, but many children with special needs do not receive timely services. Now, time allowing, I would like to focus on 2 persistent and systematic barriers that cause these delays and to propose potential solutions that can be addressed by DHCF and the managed care plans. The first one is provider shortages of critical specialty services. Children with special needs often have a need for multiple and highly specialized therapeutic services. These include vision, speech, occupational, and behavioral assessments and therapies for which in-network providers often have months-long waiting lists or lack the specialized skills or experience. For example, to obtain a neuropsychological evaluation at Children's National, a child can wait up to a year. There are no vision therapy providers in HSCSN's network or any other managed care plans to address complex vision problems. And these are just a couple of examples. Now, some of the providers of specialized services do not accept any insurance and are unwilling to contract with Medicaid managed care plans. Even if a managed care plan is willing to enter into a single case agreement with an out-of-network provider, that provider may refuse, and the child is left as, is out of luck or with no in or out-of-network provider available to meet their need. When this happens, some caregivers end up paying for these services out of pocket. These caregivers, who are already stretched thin, both financially and emotionally, are shouldering the burden of a system that cannot find a way to provide their children with the medically necessary services that they need to treat their complex medical conditions. Currently, managed care plans push back on reimbursing caregivers for their out-of-pocket expenses for out-of-network services. And in the instances that they do so, it is often after an appeal or a fair hearing and often reimbursed at very low Medicaid rates. This leaves caregivers with large unreimbursed expenses for medically necessary services and supplies for their children. There's one option that can alleviate, although not fully resolve this situation for some caregivers, and that is for DHCF to give managed care plans the ability to authorize out-of-network services, supplies, or equipment when in-network providers are not available within the 30-day standard that the district has set for timely services, and to reimburse caregivers promptly for their out-of-pocket expenses. This can be done either through statute, regulation, or even a contract requirement. But because my time has run out, I encourage the committee to read my testimony concerning the shortage of personal care aides and a short-term solution to address that issue. Thank you for the opportunity to testify, and I would be very happy to answer any questions.
Thank you. Mr. Gallagher.
Good afternoon, Chairperson Henderson and members of the committee. I'm Kurt Gallagher, Executive Director of the DC Dental Society. Thank you for the opportunity to testify today on the experiences some of our members have had working with MCOs. There's a theme that emerged from the feedback we received from our members when we asked them about challenges in their experience, and that is the inconsistent practices between the MCOs. You've heard from some of my colleagues speaking to some of these issues as well. One of the issues that we do want to highlight is credentialing. DCDS, along with DC Primary Care Association and other healthcare associations in DC, support centralizing the credentialing process. Another problem related to credentialing that we've become aware of recently is that MCOs are requiring information as part of the credentialing application that go beyond what's required by CAQH, an organization dedicated to streamlining and creating efficiencies and consistency across healthcare plans in the district. Another result of the changes that are imminent to Medicaid and changes to the Alliance program is that there will be more pressure on all Medicaid providers and FQHCs as well. FQHCs, I learned, are paid a low and flat fee per encounter, i.e. per visit. And the results of that is that care provided to the public can be extended as a result of these payments, rather than paying the facility based upon the care that's actually provided to the public. And then finally, I also want to highlight a third area, again, where there is inconsistency between the MCOs that creates problems for the ability of our members to provide care and the public to access care. And that relates to the promise to pay. The MCOs have various requirements regarding pre-authorization. And in some cases, they may even claw back funds that have been paid to a dentist upon audit for care that was promised. In one case, and you may hear from one of our fellow dentists later on about this, the MCO in question, quote, changed their mind regarding the reasons why the funds need to be returned to the MCO. Thank you again for the opportunity to testify. I do see from the witness list that the two other dentists who are scheduled to testify, Dr. Albert Coombs and Dr. Cassandra Wright. I hope they're with us and you'll be able to hear from them today as well. Thank you.
Thank you. Mr. Gallagher, yes, Dr. Coombs is, he's not next. He's one behind Mr. Cunningham. But Mr. Cunningham, when you're ready.
Chairperson Henderson, members of the committee, thank you for the opportunity to testify before you today. My name is Thomas Cunningham. I have been a DC resident since 2005. The purpose of my testimony today is to thank the DC government for helping my child survive, grow, and thrive. Specifically, my family thanks the City Council, the DC Department of Healthcare Finance, and the team at HSCSN, Health Services for Children with Special Needs. Our son Jack was born in August 2017 at GW Hospital. It was a high-risk pregnancy. He arrived 6 weeks early, weighed barely 4 pounds, and spent almost 3 weeks in the NICU before going home. He had very low muscle tone from the start and was examined by every doctor you could think of. He was diagnosed with cerebellar hyperdysplasia and hypoplasia. When asked what to expect, we were told, "Now the waiting begins." When we asked what treatments to pursue, we were told, "It depends on your level of risk." We were told he may never walk or talk or go to school. Jack struggled to gain weight and was diagnosed with failure to thrive at 9 months. He was given a feeding tube via surgically fitted gastrointestinal button. Most of the calories Jack consumes is via that feeding tube, a tube that runs all night, every night. In 2018, we were very fortunate to qualify for HSCSN through the Katie Beckett program. That program, as you may know, is an eligibility pathway for Medicaid to provide care for children with complex medical needs, regardless of their parents' income. HSCSN is billed as Jack's secondary insurance after going through my wife's or my primary insurance. Through this program, we have been able to provide Jack with his medical supplies and devices, feeding tubes, ports, syringes, and high caloric density peptide-based formula that are delivered monthly straight to our home. Just as crucially, HSCSN has allowed Jack to receive outpatient therapies, speech, physical, occupational, and feeding, augmenting the care he gets from specialists at DCPS under his IEP plan. We have felt very well supported by our HSCSN team, not just in what it delivers, but how it delivers. Our care manager, shout out to Miss India Ford, is attentive and has helped ensure the continuity of Jack's care across various services and bureaucracies. It has been a long road, but thanks to the comprehensiveness of the care provided, Jack is making amazing progress. Today, at age 8, you wouldn't notice a thing. He loves swimming, riding his bike, camping, and talking about monarch butterflies. He is sensitive and kind. This year, for the first time since he was born, Jack weighed above the 0 percentile for weight at his age. He has graduated out of all of his therapies except speech. We are now working with his pediatrician, gastroenterologist, and dietitian to reduce his nightly feeds and increase his oral intake. The volume of the feeds are down about 20%, but his weight is holding. At the current rate of progress, we can see a future when Jack no longer needs HSCSN services. But until then, and for the rest of our lives, my family will be very, very grateful for them. Thank you.
Thank you. Dr. Coombs.
Hello, everyone. Thank you so much for having me on. My name is Dr. Albert Coombs. I am a dentist in Washington, D.C. I'm a proud Medicaid provider for the last 14 years, and I'm in Benning Road, Northeast Washington, D.C. My reason for coming on is that, the relationship between provider and MCO is incredibly important. As somebody who has been in the network for a long time and have worked with a lot of MCOs, I can tell you that the combination of working with the insurance company and a dental director is critical to providing care for the patient. There are many scenarios where everyone can win, insurance company, doctor, and patient. And then there's times where it can be a road barrier. And I wanted to share one of each for now. I wanted to start with the positive. Our office takes AmeriHealth insurance. And I am one of the few providers that places and restores implants and takes government insurance, which means there is a massive bottleneck to a very small office on Benning Road for implant services. There have been many times where the insurance company will reach out to me and explain about extraneous circumstances that a lot of times are outside of the normal scope of dentistry, and I've been happy to provide services and vice versa. I just wanted to share one particular anecdote where there was a young lady. She was 17 years old, lost her front tooth in a horrible accident, and was in a scenario where she needed to wait a time period before getting an implant in. Reaching out to the insurance company, connecting with them, they allowed me to get her a temporary prosthetic so that she could go her senior year of high school with a front tooth. And then once she became of age in growth, we were able to place an implant in. And as of today, she walks around with a front tooth. And that's a great example of a win-win for everybody involved. and something that I love about working with a really good MCO. And so I really wanted to accredit AmeriHealth and their entire team for a scenario. And this is something that we do on a regular basis where we are handling special cases, especially with implants. I did also want to share some of the challenges. There is, and I won't mention the name of the MCO, where we went through a really challenging audit. And the challenging part about the audit is that we were accused of upcoding procedures that prior to the procedures, we reached out to the insurance company and requested pre-authorization. And they approved those procedures, and those procedures were done. And then a year later, when we went through the audit, they determined that these codes were upcoded and we should use a lower code. When we submitted information showing that they approved these codes prior to the procedure, their statement was that we reserve the right to change our mind in the future over decisions made in the past. That audit was so detrimental to our practice, shutting us down for 6 weeks in terms of getting all the information together, hearings, a lot of meetings, but it's so detrimental that I actually left the network because we could not afford to provide for that MCO. So I just want to get on to say that it's very important that we work together with the MCOs and providers to make sure that we can able to provide services for the beneficiaries, because that's what we're here for. Thank you for your time, and I'll stay on for any questions.
Thank you. Thank you, Dr. Coombs. Anne? Oh, okay. Anne, we see you in the waiting room. You have to accept our invitation to become a panelist if you want to testify. So I'm going to go to Jimmy. And if Anne, you're not here when Jimmy's done, then we're done because I got to get to the other witnesses. All right, Mr. Williams.
Hi, I almost said good evening, but sorry I missed the in-person testimony, but good afternoon. So I'm Jimmy Williams. I'm president and CEO of the Washington Literacy Center. As background, for more than 60 years, Washington Literacy Center has helped DC residents build their skills, the skills they need: reading, math, digital literacy, career readiness, and what we're here today for, health literacy. Reading and math remain our foundation, but literacy in all forms is critical to the strength of families and communities across DC. I'm here today to express my support for WellPoint and for our partnership we've built together. Our collaboration is focused on one goal, and that's expanding health literacy for some of our city's most vulnerable residents. Several years ago, Washington Literacy Center launched a campaign highlighting challenges our learners face every day. When you can't read, comprehend, or navigate a system, you hesitate to seek care. You may not take your medication correctly. You may struggle to follow a doctor's orders. These barriers are not small. They directly contribute to the life expectancy gap between residents, for example, in Ward 3 and those in Ward 7 and 8 in other parts of the city. I was encouraged by an article by East of the River written by Adrian Jordan, the president of America Group, now WellPoint. His message was clear. It shapes the well-being of the entire community. The message reflects exactly what we see at Washington Literacy Center. The shared vision allowed us to create meaningful programs. So together, WLC and WellPoint have built a trust, opened educational opportunities, and reached residents across age groups and neighborhoods. Just last week, we joined WellPoint for a community resource fair. My staff and I were really thrilled to connect with residents, share programs, and provide information that could lead to just the kind of education that's needed to help our residents provide and have healthier lives. And we're not stopping here. There, in months to come, WLC and WellPoint will host literacy education events. In 2006, we'll have a health literacy roundtable, and much more. And I have to stress, these efforts are not symbolic. They're practical steps to reduce disparities and encourage positive and improve outcomes. I've worked at Washington Literacy Center for more than 8 years, and in that time, I've seen the cost of fear, distrust, limited skills in an already complicated medical industry, as you've heard today. Too often, the barriers keep our people from fully engaging in their own health and future. So I believe partnerships like the ones we have with WellPoint give us the tools to change that. On behalf of the Washington Literacy Center, I want to thank WellPoint for their leadership, which is not new. They've been at the table for a long time, as evidenced in the East of the River newspaper and their outreach. I also want to thank you and the committee for recognizing that health literacy is central to health equity and all you do to make sure it's equitable and fair. We look forward to working with you, the committee, WellPoint, and with the District of Columbia to build community trust and to help our residents live healthier, more independent lives. Thank you very
Thank you.
much for your time.
Thank you. Thank you to this panel of witnesses. Oh, Anne's here. All right, Anne.
Yes, good afternoon. My apologies for the delay. So I am here today representing the SUD DC Coalition. It represents community-based peers and recovery organizations and providers to address the district's opioid and substance use crisis. One of our key issues and concerns is access to care. Inadequate provider networks, especially in Ward 7 and 8, need for timelier and more coordinated care. Delays from prior authorization and transportation gaps create barriers to timely treatment. The current MCO rates do not cover the cost of care delivery. In the past few years, several residential substance use providers have closed, and many others are facing financial hardship, raising the probability of additional closures. Frequent delays and denials in payment destabilize smaller providers. There are also discrepancies in the service rates between the MCOs and the rates established by the Department of Healthcare Finance. There's a lack of outcomes-based incentives to reduce overdoses and hospital readmissions. In terms of care coordination and integration, there are weak connections between behavioral health, primary care, and social supports. Referral platforms often fail to produce closed-loop outcomes. There needs to be more equity and accountability. Our Black and Brown communities experience higher overdose rates, but fewer high-quality services. There's limited transparency around MCO denial rates, network adequacy, and outcomes. And community and faith-based organizations face barriers to direct contracting despite deep community ties. The emergent needs in our community, fentanyl, xylazine, require stronger strategies to combat these. Housing instability drives repeated ED visits and hospitalizations. What we recommend and ask the community to consider is to mandate public reporting of MCO denial rates, network adequacy, and outcomes by ward and race ethnicity. Require reimbursement for peer support services to be on par with services offered to core service agencies. Enforce timely payment standards to stabilize providers. Strengthen integration requirements between behavioral health, primary care, and housing. Support community-based partnerships by requiring direct MCO contracts with grassroots organizations. And create work groups to bring together the individual MCOs and DC SUD coalition members for ongoing discussion regarding the challenges in serving the district. Thank you.
Thank you. All right. Thank you so much to this panel of witnesses. Melissa and Thomas, I wanted to ask a question. First, thank you both for being here and being willing to share your story. I'm curious, but for the medical providers that you all interacted with who provided a suggestion around HSCSN, do you feel like you would have come about knowing about the program in another way?
Initially, no. In those first, months and years, I was so inundated with life and death brain surgeries and medical appointments that I honestly don't think I would have come up with it on my own. As we moved out of early intervention and needing to find providers on our own, I think that's when we might have heard of it and come to it on our own, but we would have come to it late. No one brought it up to us in those initial years organically. But they did start bringing it up again in later years.
Okay, Mr. Cunningham.
I think so, sorry, similar response from me. We were buried for the first couple of years, and if we didn't have our pediatrician saying you guys are overwhelmed and your insurance isn't covering everything, here's an option, we wouldn't have been able to pursue it. And the Katie Beckett program was relatively straightforward. And yeah, I think we would have explored it later when we would have to make difficult decisions about what care to pursue or not to pursue, as well as exploring, what services would be available in Virginia or Maryland. And that's why we continue to live in the district, is because of the wraparound benefits, which are critical. So thank you.
Yeah, no, thank you. I mean, one of the things I wonder about sometimes is that there are families for whom, for whatever reason, they've never gotten information about HSCSN, and so they are kind of doing it alone, but also under tremendous financial strain in trying to sort of make all of it work. And so how can we do better to make sure on the front end, when we have cases that we suspect where the individual might qualify, either through Katie Beckett or others, that we try to get them that information as soon as possible. But thank you for being here. Ms. Sanchez, yeah, I'm with you on the shortage of PCAs and the shortage of specialists and we've got a healthcare workforce shortage issue out the wazoo for a variety of things: occupational therapists, speech therapists, physical therapists, you name it. We are behind in terms of the numbers, and we're trying to work as creatively as we can, particularly with our regional partners in Maryland and Virginia, to try to ease up in terms of the licensing process. But we'll certainly take a look at your testimony to see what other suggestions we may be missing there. Mr. Gallagher and Dr. Coombs, thank you for your testimony, and again, your consistent testimony, because we were able to raise the rates, albeit not a lot, but we were able to raise the rates for dental this past year for Medicaid, primarily out of your advocacy and testimony about how far behind the district was and the number of dental dentists who were opting out of Medicaid altogether. Dr. Coombs, I wanted to ask you about something that you said around we reserve the right to change our minds. Interestingly enough, Dr. Chapman, who testified in person earlier, had a similar retort that he had heard from the MCOs as well. And it kind of seems strange to me, because I would think that there's a contract, right? So to be able to reserve the right to change your mind 2 or 3 years after the fact seems incredibly broken of a contract to me.
Yes, and it was heartbreaking, because you imagine, one of the particular cases was a full extraction indenture case. So it's a year later, the patient has his teeth, which it's excellent. He was able to benefit from that insurance, but the margins are not great anyway in terms of extractions and dentures. So to just cut that to now it's a negative. I had to really make a really hard decision. AmeriHealth does have a large percentage of the beneficiaries in the city, but it's still hundreds of thousands of people on these other MCOs. And I don't know where they're getting implant services, or they may have to go to Washington Hospital Center and find a second provider to restore. It's just a lot of stresses that you don't want to put on the patient, to have to go to multiple places when there is an able-bodied person in Ward 7 that does this twice a day, every single day, that particular procedure. So yeah, it was heartbreaking enough to leave the network. Most of the people that know me, I've been, a very proud Medicaid provider in the city for 14 years. So for me to leave a network, it just put us in a bind.
Yeah. And again, like I said, you're not the only one. We had a situation earlier this year, where I had to reach out to the CEO of a Medicaid managed care organization to get a resident an appointment for dental. because they could not find a doctor who would take the appointment. So, and that resident knew enough and had, the wherewithal to say, okay, let me reach out to my council member. But the number of people out there who might not have that. And when we talk about the questions around network adequacy, this is one of those things. You all have options, your businesses as well. And so we'll ask some questions about some of that as well. Mr. Gallagher, we definitely heard you in terms of the credentialing and billing and the inconsistent practices there. Like I said, that has been sort of a theme of some of the earlier testimonies, so we'll follow up there as well. I don't have any further questions. Please make sure you upload your testimony for the record if we don't have it. And thank you all for being here. Appreciate it.
Thank you. And thank you again for the increased fees.
All right. Okay. So we're going to now call, it says government witnesses, but you're not really government witnesses. You're just our contractors. So Karen Dale for AmeriHealth Caritas, Jocelyn Carter from MedStar Family Choice, Adrian Jordan, WellPoint DC, and Anita Dunn from Health Services for Children with Special Needs. Oh, sorry, Anna, not Anita. My apologies. Okay, so technically we have said to all of you that you have 10 minutes. But, how long we stay here is up to you. So take liberties in editing perhaps your presented testimony as we all have your written testimony. Otherwise, we'll be here for a while. Okay, Karen, you're on the witness list first.
Good afternoon, Councilmember Henderson.
Oh, wait, hold on. Hang on. I'm supposed to swear you all in. If you will raise your right hand before you begin. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. All right. Now, Karen.
Good afternoon, Chairperson Henderson. And well, we don't have members of the committee, but maybe they're watching. I'm the Market President and CEO of AmeriHealth Caritas District of Columbia. We have proudly been serving district residents for the last 12 years. We believe that it's really important to give our enrollees what they need in a timely way, serve them with dignity, and continue to improve in ways that give them the fairest and just opportunity to achieve good health and well-being. And we work diligently every day to make that happen. I will highlight 4 key areas of our work based on the information that you requested. And I know when you ask questions, I'll have an opportunity to explain some of the things that you heard in the fullness, because we are a highly regulated industry, and it is not easily understood or known, all the context around some of the things that continue to plague us as issues and that we work to improve. The first area I will highlight is care management. One thing to note, and you've heard me say this before, is that care management is voluntary. And so we make every effort to engage and educate and improve health literacy so that our enrollees know what the benefits are that they have, both from a health care perspective, behavioral perspective, and what we can offer around health-related social needs. And so we work to have a team of individuals, nurses, social workers, and non-clinical supports that are able to give people what they need over the time that they choose to engage in care management. We can't hold them hostage to stay in care management. They have to want to participate. We work with them in a co-authoring kind of way where they are helping to set the goals that we believe will help to lead to better health and well-being. The journey of our engagement with our enrollees really begins with listening and empathy, because they do have a choice about whether they want to continue in the relationship. And we work very hard to build trust. And then from that foundation, we create that path together to hopefully getting them the things they need. We're very proud of all the partnerships that we've had that go well beyond the contract and anything that has been regulated or forced. So before doulas were required as a benefit, we offered doulas as a benefit. We offered Lyft and Uber for transportation, recognizing when we listened to our enrollees and we listened to our providers and other stakeholders, that transportation often comes up as a barrier because childcare is expensive, and the time off from work for hourly workers raises a concern and a forced choice that can be detrimental both to their health but also to their financial well-being. In 2024, well, every year we work harder to leverage the trust and acumen of our community-based organizations around issues such as pregnancy. Our partnership with Mama Toto Village has been very effective in the way in which they offer peer support services. Our partnership with Children's Law Center has really helped in terms of their legal advocacy so that we see less children with pediatric asthma repeatedly going to the emergency room because they push the landlord to address the conditions that cause triggers and emergency room visits. Our care management program has scored a clinical audit benchmark of 95%, our complex care management 97%, and our Bright Start team 98%. And we don't rest on those laurels. We continue to think about ways in which they can continue to grow and adapt in order to support our enrollees. A lot was talked about in terms of network adequacy. To note that in the contract, we do have network adequacy standards, which we meet. However, we also have standards in the contract that say if an MCO cannot provide and locate someone in network, that they must find someone out of network. And I think you and I have had those conversations. Where we find ourselves in the district is not having as many providers, right? And so, things like interstate compacts and those kinds of things are certainly solutions that the council and Department of Healthcare Finance and DC Health could consider to help to make it so that we have a larger pool of providers that can contract with Medicaid. In terms of pharmacies, you may have noted that, some of the larger chains have started closing pharmacies. I want to share a few of the things that we do to make it so that people still get their needed medication. We offer a prescription delivery service with some of our pharmacy partners. Our team of community health workers will pick up pharmacy fills for an enrollee who may have challenges and take it to them. We provide transportation to the pharmacy after a medical visit at no cost. We offer a mail service, and we also utilize a meds to beds program with the hospitals so that people can get their medications before they leave. A lot was said about dental. We celebrate the fact that the rates have gone up because we think that will also help more dentists to sign up and accept Medicaid. One of the things that I believe is not well understood, and we are working on this, is that when our current directory does not reflect specifically pediatric dentists, because many of our general dentists already they do accept pediatric patients. So what we're doing is updating our directory so that we will specifically say that they accept pediatric dentists so that that they are a pediatric dentist as well, so that people will know that they can schedule appointments for children there. In terms of our hospital focus, there's a contract requirement to be contracted with all the hospitals and their outpatient practices, the federal qualified health centers, and the lookalikes. We partner very closely with the hospitals in terms of discharge planning. We have staff that are embedded on site. We have community partners around behavioral health and other chronic conditions, especially for people who are experiencing homelessness, that we go and we build that bridge before the person is discharged and help them navigate after. We have a very robust behavioral health program in terms of McClendon Center, working with adults who present to the ER that have behavioral health issues. We leverage technology as well to make sure people can get telehealth visits. And we fill in the gap with other CBOs around helping people to navigate how to get permanent supportive housing when needed. Very proud that we continue to innovate around how we bring care to people. We just started a partnership with Altruix, a pharmacy that will coordinate with us and our enrollees to prescribe long-acting medications to treat schizophrenia and opioid use disorders. In terms of primary and specialty care, every enrollee is assigned a primary care provider if they do not select one. probably the systemic issue there is that if you get assigned one, it's not as present, even though it's on your ID card, right? And so we do a lot of outreach and education when someone first is signed up with our plan in order to give them that information and reinforce that if they don't want the one that we selected for them, that we can certainly help them to choose someone else. In terms of maternity, a lot of focus we have is around making sure our birthing persons come into care earlier. And we do that through a lot of outreach, but also leveraging our partners and health literacy materials. I know you'll ask more about credentialing timelines. I wrote down that you made the statement that we leave a provider dangling. And I brought examples to tell you what it is that happens in the process that creates issues and concerns. And we are just as concerned for all the reasons that I just stated, that we want to have as robust as possible of a network. I'd also, I'm sure, answer your questions around prior authorization and the timeliness of that. Please note that every year, the Department of Insurance, Securities and Banking requires a comprehensive report on prior authorization, and then the Department of Healthcare Finance also very carefully tracks prior authorization. The issues are in coding that happens with providers and other things that we can talk about, and I can explain why it works the way it does. Not perfect, but providers do have lots of opportunity for remedies in terms of appealing, which I know does take time. So finally, what I'd like to say is that we believe and we wake up every day looking for ways to ensure that every enrollee that's part of our plan has a fair and just opportunity to achieve optimal health. And this drives our ambition to innovate, collaborate, and advocate in ways that go beyond the contract standards. And we partner with key stakeholders, providers, and enrollees to listen, to make sure we understand before we act. I firmly believe that a health system fueled by Medicaid coverage and enabled by high-performance managed care organizations has a lot of value for district residents. And I look forward to how we work together to create more thriving communities in the work that we do.
Thank you. Ms. Carter.
Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Jocelyn Chisholm Carter, and I am the president of MedStar Family Choice for the District of Columbia and Maryland. For today's roundtable, my testimony will be confined to our activities in the District of Columbia. As you know, MedStar Family Choice, being a Medicaid managed care organization here in DC, we serve 63,000 individuals that reside within the District of Columbia. First, I want to say at the outset, we are committed to ensuring that the people we serve have access to the highest quality of care and care coordination to ensure they are living healthier lives. With over 100 associates employed to serve our DC enrollees, each associate is committed to ensuring that our enrollees are treated like family, as we take the words family literally. MFC DC is proud to partner with the District of Columbia, and we do look forward to a long and continuous prosperous relationship. I appreciate the opportunity to present today, and our presentation and discussion will be based upon the questions that were provided. You do not have to show the slide presentation, because I'm going to move quickly. You don't have to show. You do have it. I will say for each of the committee people, you do have a copy. Yes, you do. So as I said, with our 63,000 enrollees, our age and sex distribution, our makeup of our enrollees is a little bit different probably than most managed care organizations. We have a majority of adults that are enrolled in MedStar Family Choice, about 66%. And the majority of those individuals reside in wards 4, 5, 7, and 8. And Chairperson, I recall you did mention about enrollees not having claims. I will say that there is a claims runout period. So in DC, providers have 365 days to submit a claim. So where we have provided the information, there may be additional claims that will continue to come in. So I would say that number is iterative of what you see today, and we do expect it to grow. but as a focus and recognizing the needs of the people that we serve, particularly in Ward 7 and 8, we have recently this year opened a community wellness center. I am proud to say that our wellness center is focused on providing face-to-face case management, health education, outreach, as well as other activities targeting specifically our enrollees in 7 and 8. Since January, we've had over 300 enrollees visit the center. We've offered about 11 programs each month, and we have embarked upon 16 community partnerships, which are outlined in the presentation, as well as information that demonstrates some of the activities that have taken place. We have also, as a testament and making sure that we want to ensure that our members are continuing to live healthier lives, have really embedded and increased our value-added benefits. Those benefits are focused on wellness plan enhancements for adults as well as children, as well as healthy nutrition. As we know, social determinants of health and food insecurity is definitely an issue within the district. So we are creating and have created programs and partnered with various community-based organizations to really address the needs of our enrollees, those who are pregnant, as well as those who are not. We are also focused on creating a fitness program and then driving a maternal health initiative around doulas. In your request, you asked about how we operate as an MCO. And as you see, we have met all of the metrics. We did have a hiccup, I will say, earlier this year in our fiscal year regarding our member appeals and acknowledgements, but we recognized that there were higher than normal volumes. And with those volumes, we have now implemented corrective action plans, redirected resources, and have created process improvements that have been implemented that are now have put us on the path that we have met those timeliness requirements as outlined in our contract. When we turn to case management, we know that that is one of the main focuses for coordinating the care and the need for Medicaid managed care in the district. We have today about 11,000 individuals that are enrolled, total enrollees in case management. Our contract requires that we have 3% enrolled, and we are meeting and or exceeding that target with those numbers continuing to grow each day. We have focused our care management program and tailored it to meet the needs of the people we serve, focused on high-risk pregnancy, as well as dedicating and creating a complex case management team. Our provider network adequacy, much as Karen shared, we do have network contract requirements that are outlined and defined in our contract. And we are meeting all of our access requirements for our members. But as Karen said as well, if we do not have a provider that is available, we do embark upon single case agreements and make sure that the members are able to see a provider that is outside of the network if need be. And credentialing, which has been a discussion here today, when we are looking at our credentialing timelines, I must say the MedStar Family Choice, we rank among the best in the industry, and we outperform current standards, the DC contract, as well as NCQA. In fiscal year 2025, to date, for a practitioner or a primary care practitioner provider, our average processing times are 28 days. And then for a provider within a facility, we are meeting at 18 days. And as I said, those are very high standards, and we are meeting those timelines that are outlined in the contract. Regarding prior authorizations, we recognize the changes in the regulations for authorization request timeliness. We have implemented several enhancements to ensure that we meet the requirements that are defined. We have increased our staff. We have created additional oversight of the staff and the individuals that we serve, that serve our enrollees here in the District of Columbia. And then finally, I will just call out our quality improvement efforts. We are fully accredited. We received our full health plan accreditation effective August 29, 2025. We have our survey that is coming up in January of next year. So we're in the middle of being reaccredited, as well as we received our case management accreditation as required by our contract. And we have another survey that will be due in April of 2026. So we will be doing a lot of accreditation and meeting with NCQA in early next year. And as well as quality improvement, we've highlighted, I'm not going to go through all of the various elements, but we have highlighted those areas where we are continuously improving in meeting our quality and HEDIS goals for our members. We are currently in the middle of still HEDIS season, and there is not only the opportunity for where we stand today, but the opportunity to improve the rates that have been submitted. We are also focused on our EPSDT metrics and ensuring that our children ages 0 to 20, that they receive the required services that they need. We are partnering with various community organizations here in the district to enhance our services and performance metrics so that we can address some of the concerns that were addressed by one of the witnesses here today. I outlined what our key interventions are. And as I look at the time, I want to make sure I hit my time. We also talk about our performance improvement projects that we're implementing as well. I look forward to questions from the chairperson as well as from the committee. But just know that MedStar Family Choice is very committed and happy to be a partner with the District of Columbia.
Thank you. Mr. Jordan.
There we go. Good afternoon, Chairperson Henderson, members of the Committee on Health, and staff. My name is Adrian Jordan, President and CEO of WellPoint District of Columbia, and I thank you for the opportunity to provide an abridged version, because of the 10-minute time limit, of my official testimony that was provided to you. WellPoint DC is one of the 3 managed care organizations providing comprehensive coverage to a portion of more than 200,000 district residents eligible for health coverage through the district's Medicaid Alliance and Immigrants Children's Program. The residents we serve maintain access to high-quality, cultural, competent health care that is bettering their lives and the communities where they live, work, and play. To some, and we heard it through some testimony today, the WellPoint name may be new, and that's because on July 1 of 2025, we transitioned from AmeriGroup DC to WellPoint District of Columbia. Today, my testimony will reflect both the milestones we've reached and the path ahead as we build on the foundation and partnership with the district. We returned to the Medicaid Managed Care Program on April 1st of 2023, and in our first year of participation demonstrated reliable operational performance and adherence to district standards, as demonstrated in the DHCF's most recently issued Medicaid Managed Care Performance Report for calendar year 23. The plan exceeded requirements for encounter data reporting and paid nearly 95% of clean claims within 30-day standard, ensuring stability for our providers. WellPoint DC also maintained a comprehensive provider network, which allowed enrollees both access and choice when it comes to their healthcare needs. Though WellPoint only participated for 9 months in 2023, initial experience signals a smooth transition back to the program and established a foundation of strong performance, particularly in the areas of compliance and care delivery. Since April 20 of 2023, it is important to note that WellPoint has had members that have had the lowest risk scores across most categories, with exception to children. This means that our population is generally healthier, younger, and has fewer chronic conditions. This creates a unique situation for us, which has guided our approach to managing the care of our members. As such, we focused on preventative care, social determinants of health, behavioral health, including substance use disorder, and maternal and child health. As a result, we've seen measurable improvements in preventative services, chronic disease management, and care coordination, consistent with the district's goals of improving population health and reducing avoidable costs to the Medicaid program. Over the past 3 years, WellPoint has made measurable progress in clinical outcomes for our enrollees. One of our focus is reducing unnecessary hospital visits and admission while improving quality of care. As an example, inpatient admissions, average length of stay have seen noticeable declines year over year. Similarly, behavioral health, emergency room readmissions have also decreased by double digits year over year. Demonstrating our progress in post-discharge follow-up and continuity of care, we have also made strides in addressing low acuity, non-emergent cases presenting in the emergency room, with reductions resulting from more enrollees accessing primary and urgent care alternatives. These efforts, outcomes, and more culminated in full health plan accreditation by the National Committee for Quality Assurance, NCQA, which you've heard earlier this year, including case management accreditation. NCQA's health plan accreditation is a rigorous evaluation process that assesses the quality and performance of health plans based on their ability to deliver high quality, evidence-based quality of care and patient-centered focus. This achievement serves as independent validation of the quality and integrity of the programs that we have, including alignment with the district's ECRO, the External Quality Review Organization measures. Lastly, we are also on track for NCQA Health Equity Accreditation with our next review period coming up, I believe, October 14th. We're not October yet. We ground our approach to a whole person care framework, enhancing the patient experience, improving population health, and reducing costs through targeted, data-driven interventions. Improving population health requires us to recognize how social determinants such as food, housing, transportation, employment impact outcomes. That's why we designed evidence-based programs to close these gaps and address these and other health-related social needs heads-on. To date, we've worked to align our efforts with the district health goal by leveraging diagnosis, claims data, and insight from our Find Help Community Access Link platform, as well as our community partners. This platform is a tool that allows us to go a lot further than what we could if we were just doing it on our own. In FY25, our priorities included advancing maternal health, strengthening chronic disease management, and addressing housing insecurity. For maternal health, we established a significant framework for which we can implement multiple strategies aimed at enhancing these outcomes there. At the end of our first year, we had 200 births, and since then, we've averaged between 75 and 80 births a month. For chronic disease management, we've really focused on pediatric asthma. That is something we've seen in our population has been a spike for us in the community we serve. As such, we have a partnership with Children's National Impact DC Asthma Clinic, where we've seen increased utilization of controlling asthma, and the clinic has achieved the 90% controller prescription rate. For other chronic conditions such as diabetes and hypertension, we expanded our collaboration using a food as medicine model with Food and Friends to deliver medically tailored meals along with nutritional counseling. Participation continues to grow, while Food and Friends addresses targeted clinical needs. Broader food insecurity requires other partnership. As such, we also work with others in the industry, Miriam's Kitchen, Martha's Table, Feed the Fridge, and Capital Area Food Bank to ensure members are matched with the right resources at the right time. Lastly, and one of the questions that you had, we're also looking at homelessness. We support the district's goal of making homelessness rare, brief, and non-recurring. We estimate that roughly 4% of our current membership may, at some point in time, have experienced homelessness. Of that number, just over half had a claim submitted for healthcare services at one point in the past 3 years. So we think that also makes up some of the discrepancies you've seen, just the unhoused population who are enrolled in the Medicaid program. I also want to talk, and you've heard about it today, our transition to value-based healthcare. The committee, your committee, FY26 budget report underscores the importance of value-based healthcare in the district, a shift that promises to significantly enhance residents' health outcomes, improve equitable access to service, and increase the efficiency and effectiveness of care delivery. Recognizing these benefits, we, the DC Primary Care Association, and 7 federally qualified health centers pioneered a groundbreaking partnership. This initiative creates a clinically integrated network that focuses on elevating quality while reducing overall cost. The Connected Care Network operates under a shared savings model grounded in a rigorous set of quality and HEDIS metrics, such as child and adolescent well care visits, lead screening, blood pressure control for patients with diabetes, and cervical cancers, just to name a few of the measures that are in the deal with the CCN and PCA. It targets improvements in pediatric, adult, and chronic health conditions by fostering a holistic, whole-person approach to care through regular checkups, prescription adherence, support, and chronic condition management. This model aims, and we've seen it early on, to reduce emergency room reliance and prevent avoidable hospital admissions. Savings realized from enhanced care management are redistributed among the providers incentivize continued excellence and truly creating a partnership moving beyond the traditional fee-for-service model. Though this is the inaugural year, initial markers of success are already emerging with increased preventable care screenings, advanced care coordination, and better data sharing practice, which is really huge in finding gaps between our data and our partners in the FQHCs. We anticipate the release of a comprehensive utilization, quality, and provider-patient outcomes in Q3 of Q4 of next year, which is coming up soon because next year for DC is October 1. The launch of the CCN deal marks just the beginning of this transformative journey. We recognize that meaningful change takes time, but this initiative sets a strong foundation for improved health outcomes over a strategically planned 3-year guide path. You've heard from a lot of our community partners. I will kind of skip over that in this abridged version, but it's important. It comes down to trust. It is not always the most trusting where your MCO or who are they and do they have my best care in mind. So we wanted to partner where our members lived, work, play, and organizations they were to expand our access to them and provide the services that they rightly deserve. Before I close, I do want to share a story of success for one of our enrollees. I think Mr. Williams talked about being at our resource fair. This enrollee came to WellPoint from another plan because she was having trouble finding an eye specialist in a network. Within a week, our team was able to get her an appointment with a provider, but we didn't stop there. Through additional outreach, we learned that this enrollee had diabetes, high blood pressure that needed managing. Knowing this, we invited her to our community wellness center and shared programming opportunities to meet her needs. This led to her completing a 6-week wellness circle series that teaches enrollees how to manage diabetes, high blood pressure. Following the program, the enrollee remained further engaged by joining our enrollee advisory committee, offering insights on how we can better deliver care and helping other enrollees like her. And just last week, she attended our 2nd annual resource fair where she received information that not only helped her, but her family with employment resources for her and her kids. Looking forward, Chairperson Henderson and members of the committee, thank you again for the opportunity to share our story as an MCO. We remain deeply committed to advancing health access and equity across all 8 wards, doing it collaboratively and in partnership, not just with providers, but with members of the community and our enrollees. And with that, I will conclude my testimony and stand ready to answer any questions you may have. Thank you.
Thank you. Ms. Dunn?
Good afternoon, Chairperson Henderson, members of the Committee on Health. I'm Anna Dunn, President of Health Services for Children with Special Needs, or also known as HSCSN. Thank you for the opportunity to provide testimony on how, on who we are and how we are delivering on our promise to provide high quality, equitable, and coordinated care to Medicaid enrollees. HSCSN is proud to be the district's only managed care organization exclusively serving children and young adults with special health care needs. Since 1994, 31 years, our mission has been focused on improving the health and quality of life of children and young adults with complex medical and behavioral and developmental needs in the District of Columbia, uniquely this population and nothing else. Our enrollees represent the most vulnerable populations in the district, individuals who require not only medical services, but also tailored wraparound care that supports the whole child and their family. In 2019, HSCSN took a bold step forward by becoming a wholly owned subsidiary of Children's National Hospital, a world-renowned pediatric institution that has served DC families for over 150 years. This unique integration makes HSCSN the only pediatric-focused accountable care enterprise in the region, greatly enhancing our ability to provide coordinated, specialized care by strengthening clinical integration, improving care transition, and expanding access to expert pediatric providers. What does it mean for our families? It means a seamless, highly coordinated care experience anchored in clinical excellence and personalized case management. Over 65% of our enrollees receive primary care from Children's National, and over 90% of our enrollees receive specialty care at Children's National. And now they're served within a fully integrated system of care that spans hospital, specialty clinics, and community resources. Even though we're a wholly owned subsidiary of Children's National Hospital, with an enrollee population of 5,000, we have a network of approximately 5,000 providers as well. again, exemplifying what it takes to serve the unique needs of the unique population in the district. As I mentioned, HSCSN currently cares of approximately 5,000 children and young adults up to age 26 who are enrolled in Medicaid and recipients of SSI and have SSI-related disabilities. We also serve the enrollees of the Katie Beckett waiver program. These are the children and youth with some of the most medically complex behavioral and developmental needs. Importantly, enrollment has always been voluntary, and individuals are disenrolled when they turn 26. Families choose to enroll with us and stay with us because of the coordinated and family-centered care we provide. Our enrollees live a series of lifelong conditions that are developmental disorders and autism, ADHD, epilepsy and seizure disorders, genetic conditions, behavioral and mental health challenges. Most of our enrollees have comorbidities and have multiple conditions. In addition to their clinical complexity, our enrollees are often impacted by social determinants of health, such as housing, food insecurity, and trauma exposure. 60% reside in wards 7 and 8, communities that face the greatest barriers to care, including poverty, housing instability, and limited provider access. To give you a sense of the intensity of care our population requires, 11% of our enrollees are assigned to level 3, which is the highest intensity care management program. Approximately 32% are medium intensity level 2, and 57% are in the period of relative stability level 1. These levels are not arbitrary and not permanent. They're based on the comprehensive intake and screening process upon enrollment. Every enrollee is assigned a care manager and a dedicated care team tailored to their acuity level. The acuities are evaluated frequently on the as-needed basis, but at least every 6 months. We understand the importance of transparency and accountability, and we're accredited by NCQA as both a health plan and a case management program. In NCQA's recent publication of health plan ratings, HSCSN scored 3 stars. This rating is based on the weighted average of all measures that include patient experience, prevention, population, and treatment. Our credentialing performance over the last 3 years averages 15 days, far exceeding the standard of 180 days. We have eliminated prioritization requirements for preventive care, patient and behavioral needs, physician specialty, and subspecialty services. We recently launched the provider prioritization portal to streamline authorization requests, further improving provider access and reducing delays in prioritization turnaround times. We also lead in value-based care. 90% of our enrollees are in value-based care arrangements for primary care. Our enrollees also have access to Easy Connect, an enrollee portal and an app that provides them with live access to their care management team, enables multi-channel communication, and provides access to specialized health literacy content assigned to them based on their needs. We are more than a health plan. We're a trusted partner in the lives of the families we serve. Our approach emphasizes personalized care coordination designed around the strengths and the preferences of each child and family, a community-based provider network with almost 5,000 physical, behavioral, and specialty providers across DC region. Our provider network meets all provider network access standards, an ongoing commitment to ensuring access to high-quality care for all of our members. Our care management team accounts for over 100 employees out of 240 employees, and they include care managers, social workers, behavioral health clinicians, and community health workers. Our results speak volumes. HSCSN received top ratings in the CAP survey, 93% for how well doctors communicate, 89% for customer service, 88% for coordination of care, and 84% for both getting care quickly and getting needed care. Additionally, our EPSDT well-child visit remains the highest among MCOs in the district, a reflection of our proactive preventive approach. While we are proud of our performance, we know we can always do better. One significant area of improvement is pediatric home health service access. Despite timely authorization, families continue to face delays far exceeding 30 days in receiving home care services. We actively partner with DHCF to implement mitigation strategies and explore innovative solutions, but this sector needs stronger systemic investment to ensure timely and equitable access for children with complex needs. In closing, HSCSM stands as a proven and trusted partner to the district, a health plan with nearly 30 years of unwavering commitment to our city's most medically vulnerable children and young adults. Our model isn't theoretical, but it is built on real relationships, real outcomes, and real accountability. We are proud of our high performance across care coordination, patient satisfaction, access, and preventive care, and we remain laser focused on ensuring that every child, regardless of their zip code or diagnosis, receive compassionate, comprehensive care they deserve. Our integration with Children's National has only strengthened our ability to deliver on this promise, creating a uniquely pediatric, community-rooted system of care. We know these children, we know their families, and we're deeply honored to walk alongside them in the journey towards better health and a better future. We thank the committee for your continued oversight and for recognizing the value of a model that has always put children first. We're proud of our past, confident in our present, and deeply committed to building an even stronger future for our enrollees, for their families, and for the District of Columbia. We remain honored to serve this community and look forward to partnering with the Department of Healthcare Finance and the DC Council to continue providing care for those who need it most. Thank you.
Thank you. I realize none of y'all have water. Hopefully your friends can provide you with some because your statements were long, but thank you so much for being here and for being part of this. We've been joined by Councilmember Zachary Parker, who's a member of this committee and Councilmember for Ward 5. We're going to do 10-minute rounds. Councilmember Parker, we need you to be efficient with your questioning, as I will need to be efficient in terms of how long the rest of this hearing will last. As we jump right in, I want to start on talking about credentialing, which is something that came up a lot in terms of the public witness testimony. Ms. Carter, you talked about MedStar hitting the 28 days average processing, which is fantastic. Frankly, I've got questions for Director Turnage in terms of why the contract requirement is 120-day turnaround, because I think that 4 months is incredibly too long in terms of moving through the system and trying to address some of these particular issues. Is this the question for the three larger MCOs, but what is normally the most common, biggest barrier to you all being able to process an application in a timely fashion?
If I'm being honest, it's incomplete information.
Okay.
It is incumbent upon the provider to submit a completed credentialing application and provide all of the information. And what we see is that sometimes it requires us to have go back and ask additional information or seek additional information. So if the application is submitted complete, then yes, we can hit those turnaround times.
Does your website have like a checklist?
I can't say the website does, but I will say providers go through what I'm familiar with is CAQH, and it is the National Credentialing Standard, which provides that checklist and the information. We also have provider advocates or provider representatives that are available to answer questions, to help navigate the provider through the process.
Okay, and your process is online or is it paper-based?
Online.
Okay. Ms. Dale?
I agree with the statement about providers not having things complete. I'll share an example which elucidates the process. So we had a provider that was to be re-credentialed. So providers get credentialed and then every 3 years re-credentialed. So in April, they sent their application in. They were advised that they didn't have, it was missing their DCDEA information. The missing information was received, so we reopened it, kept going, and then they did not have something expired in CAQH. That's one of the most common things, is that providers are not going into CAQH. So it may have been current when they first submitted, but they didn't look to see if something was going to expire. So if it expires during the recredentialing process, we do reach out to them again and request that they update CAQH. I fully recognize that providers are running a practice, seeing patients and all those things. So they, might be someone else in the office that gets the reminder or the request. But that cycle is what extends the recredentialing or credentialing timeframe where information is needed and it's not provided timely. And if we get to the end of pretty much the time frame for a recredentialing or a credentialing, then we will close it, because keeping it open after several reminders and not receiving something just puts us out of compliance with the national quality standards. And so it's that missing information that tends to be the hang up over and over again.
What's the average turnaround time for AmeriHealth?
Let's see, we put it in let me see. I think it's under 60 days. I can't remember the exact, but I know it's under 60 days.
Okay, Mr. Jordan?
So I would concur with the statements made before. I can tell you we see credentialing between 3 and 4 weeks at WellPoint. And that is through our digital platform, Availity. I will tell you where in addition to what was said before, where we see delays and longer times are when providers do choose to use paper. That would be the only other thing I would add, when they choose a paper process.
Okay, so what would you all say to the two individuals, the doulas who testified earlier, talking about how they've been trying to get credentialed with you all for over a year? They weren't specific in terms of which companies, or maybe they were. Let me go back.
The doula process is a little different.
Okay.
Because they have to, what's the right word? Another entity is used to make sure that they're meeting all the requirement. There's certification, that's what I was thinking. And sometimes, again, that's a newer process, but they have not completed the process or met the standards. And that's limited our ability to contract with as many doulas as we would like. One thing that doulas sometimes report back on as well is that the insurance requirements for them as really, in a sense, a solo practitioner are higher than they are able to afford. So the doula situation, I think, requires maybe some different thinking, because it's not just a pure credentialing process going through, for example, CAQH or Availity.
Are there other types of specialty providers that have that similar alternative system?
I don't think so.
Like, I'm trying to understand why doulas are so unique when you do have other types of providers who are not physicians that are part of your network, right?
Most other providers in our network are some sort of clinicians. If you think about even nurse practitioners or nurse midwives. So there is also their licensure that brings us a lot of the information. Since doulas are not licensed per se, they are certified. And
correct. Midwives are licensed.
Correct.
Which is different. Okay.
And it shouldn't be more of a barrier. This is newer for us as a jurisdiction, and we have to work through how to support them in getting through the certification as well.
Okay. What's your reaction to the suggestion around standardizing credentialing?
Well, this is something I think we talked about earlier, and we had a letter. I don't recall exactly what the letter said when this came up. I think this was during the budget time, but I can tell you where we are today. We're open to all things. We just want a seat at the table as it's being developed if we're going to have to implement it.
The seat at the table is important because we are required to be NCQA accredited. So if something is designed where, for example, how the information is transmitted to the MCOs is not timely or digestible in our systems, that would cause further concern for us. But if the district intends to fund this and have us at the table to create or co-author a strong system, there are other states in the country that do this for certain. So it's not something that's unforeseeable. It would all come back to the design of how it's done so that it doesn't harm our NCQA accreditation.
Okay. I want to turn to talking about claims for just a moment. So Department of Healthcare Finance data showed that MCO claims denial rate, and this is for calendar year 23, was 16.1%, which is on par with the national Medicaid denial rates, but it's definitely higher than Medicaid, as well as our commercial plans as well. We don't have the numbers yet for calendar year 24. But if I'm looking at individually, some of you have higher denial rates than others. And, you know, I'm trying to understand what work you all are doing to lower the denial rate. Yes, we're in par with the national average, but I still think that 16.1% is, on average, is high for a jurisdiction of our size.
I will jump in because I don't think our information was in there. In 23, we had a denial rate about 15%, 24, 15.8, but in 25, we're tracking to 13.8%. A lot of that's provider education. A lot of providers use third-party billing services, which create complications and things get flagged. But what we use is our healthcare networks, our provider relations team, to really go out and work with the provider so that they are going to get their claims successfully through. It's just really a lot of education that we have to do, but we only see it when you get the data and you realize there's a problem.
Well, even if we wanted to do a training on coding, right? Because I think for some of these, we asked like, what are the top 5 reasons as to why? All of you have different practices in terms of billing. So it would be that each of you would need something different, because we did have providers that talked about how one MCO would accept one code, one of you would deny that code and say you need to use a different code. So even within the family of coding, some of you are accepting things that others are not accepting. So how do we rectify that so it's more consistent across the board?
Okay, I'll take a stab at that. What I would say, I think for all of us across the board, we pay for medically necessary claims. That's the baseline, that we have to make sure claims that services provided for our beneficiaries or enrollees are medically necessary. Claims that are submitted, yes, we have a responsibility to review them. If there is a concern, we often, and not often, we reach out to the provider to ask them to provide the medical records. Or as Adrian said, we have our provider relations team work with the provider. I will say MedStar Family Choice, and I probably can speak for my colleagues over here, none of us are in the business of trying to just deny claims. But we also do want to make sure that our taxpayer dollars are paying for claims for services that are medically necessary. And each of us use certain clinical criteria to review those claims. Some may use MCG guidelines, some may use interqual guidelines, and so those are what we comply with. The upcoding, I think that is, and if I'm being honest, I think that's a term that is just thrown around. Upcoding oftentimes relates to fraud, waste, and abuse. And there is no allegation of fraud, but we are required to conduct an audit if we see something that gives us pause or gives concern based upon the guidelines that we operate within. And I hope that answered your question.
Sort of.
Okay.
But I'm over my time. Let's put a pin in this. We're gonna come back to it. I'm trying to be respectful. Councilmember Parker.
Thank you.
Been patient.
I will continue here. So again, it looks like across the plan, 16.1% there was a denial rate of about 16.1%. Can you all pinpoint what the numbers are for denials that have been reversed and approvals that have been reversed? Because we've heard testimony about those things today. So your plans have said, yes, this procedure or treatment is approved, and then later, because of an audit, it is reversed. And I know I'm just throwing that out. So if your teams can dig up those numbers, 2 things. How many approvals have been reversed? How many denials have been reversed? That would be helpful. And then I wanted to ask a very specific question. Thank you, Ms. Carter, for this very handy printed out packet. I noted here you talked about it was member appeals and how you created an action plan to get that back on track in fiscal year 25, if I remember that correctly. Can you just elaborate on briefly what that action plan includes?
So it included adding additional staff and also contracting with additional resources vendors to help us bring down the increased inventory. And then we called it, we burned down the inventory. We met on a weekly basis. We looked and saw what the patterns were and also some of the issues we, may have reviewed and just approved them, for lack of better words. But we brought in additional resources, and now we are looking at monitoring those that come in and ensuring that our teams are meeting the deadlines as well as our vendors are meeting those deadlines.
Awesome, super helpful. This may be a very niche question, and I'm happy to follow up if necessary. As the chairperson of the Committee on Youth Affairs, I have oversight of DRS, or our Department of Youth Rehabilitation Services. Its Youth Services Center, or YSC, is routinely overcrowded. One of the issues they are having is a challenge with placements, specifically specialized placements for youth under its care. As we know, young people's Medicaid coverage, when they are covered, is suspended while they're in detention, and then it's resumed as they're exiting. One of the things we routinely hear is that engagement with MCOs contributes to the delay in placement as DRS is trying to get approval for X placement. Again, I know that's a very niche question, but I would love just better insight and data, if you have it, on claims approvals as it relates to young people in the care of DRS. And I'm happy to follow up after the hearing, unless anybody is prepared to answer that right now.
I'm gonna have to follow up.
Yes, understood.
I can answer maybe a little bit more generally, kind of two things. One is HSCSN denial rate is 3%. So, but I think that's expected given the population that we serve. And the majority of the denials are pharmacy related, and I would say about a quarter of those denials are overturned based on the additional information that we receive from the provider supporting medical necessity.
Okay, that is helpful.
Yep.
So 3% total
3%
denials.
total denial rate.
And a large portion of that,
Pharmacy.
You said a quarter is at least from pharmacy.
Yeah, a majority of them are pharmacy denials, and about a quarter of the pharmacy denials then overturned on average.
Okay, got it. One other thing that I heard through the public testimony that I wanted to lift up was coverage for out-of-network treatment when those treatments are not provided in network. Do you care to elaborate on or speak to what we heard today from the parents and others who spoke about that being an issue, desperately seeking out care when it's not in network?
A majority of our enrollees that receive care outside of the network or receive care for PCA services, the services that we cannot staff, somebody else delivered, whether they're found somebody through care.com or another provider. And then we do have a wait list, the service delay log for primary care service, or for primary care, I'm sorry, for PCA services, specifically for pediatric population. 18 and up, there is no wait list. We're good for adults. Pediatric care is a challenge. So then the challenge is then when they submit for reimbursement, the reimbursement process is not really, it's not family friendly at times. I think especially if there is a primary insurance involved, then the enrollees have to submit for any out-of-network, they have to submit the denials or EOBs from the primary care insurance and fit within the 60-day time frame that is allocated by the rules. So with that, it time constrained at times. For the out-of-network PCA reimbursements, the majority of the reimbursements we do pay the families, recognizing that, there is a shortage of the providers. We're also launched the value-added benefit this year, where we sponsor the training of family members to become home health providers, CNAs, then get employed with one of the home health agency to be able to, add to the pool of the service workforce and provide care for their enrollment.
Jumping in just for the sake of time, if you could follow up with the committee on your concrete numbers as it relates to out-of-network claims, timeline, and approvals, that would be helpful.
Absolutely.
Okay, thank you. Councilmember Henderson may know this, but when we hear the term down coding, I'm assuming that means the doctor said I should receive X treatment. The MCO is saying they're only going to cover me for X treatment, which is a less expensive treatment. Is that fair? Or how would you define down coding?
There are a couple of things to consider in terms of context. When the coding is not my thing, but I can explain it, right? So there are specific codes that are both relevant to the diagnosis, the treatment, and whether there are other things. So there are modifiers, right? So there's what's the appropriate code? Is that code on the district's fee schedule? Is that code listed on the attachment that we have to all contracts, which says this is how these are the things based on your contract with us that we will pay? I don't think you were here, but maybe you were listening. Dr. Chapman said, I've been doing this for 45 years. Do you know how many times the codes have changed? And so oftentimes people are billing. I'm not saying they're doing it on purpose. They're using the wrong codes, and they may be using the wrong modifier with that code. So our systems will flag those. What's important to also note is that we always give the opportunity for the provider to correct it. So they can resubmit the claim correctly, which may not need to be a lower code, right? Saying it's all being down coded is not a precise way of describing the issue, because
so I should interpret that not as down being less, but just different.
Yes.
The coding is different. Okay.
Sometimes it may need to be a down code because the medical record doesn't match what they said, what they coded for, but we have to look at that record before we can make that determination.
Okay. One other thing that was really concerning also, someone flagged that they received pre-authorization and approval, yet when the audit occurred, then they received a reversal or callback of funds. That's related to my first question, where I would love to know how often that's happening. I have not heard from Mr. Jordan, so I'm going to ask you a question. I'm trying to be respectful of the clock. Can you speak more about the RISE program and its effects on dealing with substance use disorder, as that's been a big focus of today's hearing as well?
Sure. When we saw the declines in BH readmissions, we saw them everywhere except for SUD. So we wanted to do something different, and my team will really be hitting their heads when I cannot remember what RISE stands for. But basically, it was an innovative approach to handle substance use and opioids here with boots on the ground analytics based on comorbidities, our algorithms. We have CHWs within our BH space. My behavioral health medical director is here, where we do targeted interventions, and in collaboration with organizations like PIW, Psychiatric Institute of Washington, and some of the FQHCs like Mary Center. So it's really using a data-informed approach with boots on the ground to actually target the SUD space.
Understood. Thank you all.
Thank you. We'll go back to, again, sort of talking about some of the denial pieces. So the claims denial rate data from healthcare finance doesn't actually include pharmaceutical data. Do you all happen to know about what percentage of pharmaceutical related claims are being denied by your organization? We could follow up on that too. Okay, we'll follow up on that one. All right. Let's talk about prior auth though. So as you guys know, we did prior authorization reform a year or so ago. You know, a day looks like another day, a Tuesday, a Wednesday, who knows? Anyway, it should be fully implemented at this particular stage in the game. In terms of the work of your companies, and this is more or less a question around, like, I guess in some ways how you all are doing AI integration, but who is reviewing your prior authorization claims? Is it an actual physician person, or are you all employing AI as part of that work?
The MedStar Family Choice and my chief medical officer is here as an actual person.
Just want to confirm across the board. So
Yes, our CMO.
CMO.
So prior authorization can start with a nurse. A nurse can approve, they cannot deny. It goes to a physician when they're not able to match to the criteria. So, you know, the turnaround time, if it's just a nurse, is usually pretty quick. If it goes to a physician, that physician is in the tri-state area and they match to the specialty of the provider whose prior authorization needs to be reviewed.
Okay. Adrian.
And everything Karen said, and in full disclosure, we are working with Department of Healthcare Finance to bring a AI implementation to the district, but it would only be for approvals, never denials. We're still going through all the IT security and things like that, but ultimately we think that would further speed up the process where we have taught the algorithm how to detect things that 99.9% are already is going to be approved by a human.
Okay. You know, one of the reasons that we ended up doing sort of prior auth, as you guys know, right? Prior authorization sort of started in terms of resource management, but it was supposed to be for specialty type things, surgeries, products, et cetera. And now we start seeing companies using prior auth for even generic medications, which shouldn't actually need prior authorization. So, you know, for instance, AmeriHealth, we looked at some of the data, your urgent prior authorization timeline. So as you know, we have different categories. It increased from 2.7 hours to 26.3 hours from FY23 to FY25. What has led to the increased response time? Is it the number of prior authorization requests have increased overall in for the organization, or is something else going on?
A higher volume in the past, probably about 12 months of requests, even though we intentionally, when the act went into place, we removed a number of things from requiring prior authorization. But still, you know, we've also seen higher utilization, so more requests coming in. You would note that the act has timeframes that include the weekend.
Yes.
And so the weekend, remember I said, I was like, that one concerns me, right?
I know, but if it's urgent, do I gotta wait till Monday morning to get what I need?
It's harder to staff, and most of the delays have occurred over the weekend.
Over the
I
weekend.
can tell you, and specifically with pediatric cases.
Okay, MedStar, yours went up to non-urgent prior authorization turnaround and went from 4.46 days to 11.4 days. What things are you guys trying to do to decrease that?
Well, let me say at the outset, part of it, we had staffing challenges at the beginning of the year with the return to work. We had a lot of people did not want to come back and work in the office 4 days a week.
Okay.
So as a result, you know, we have hired additional qualified nurses and support staff. We also do have a prior auth list as well, as referenced. And I would say for the past 2 months, we have consistently hit our target with those interventions that have been in place.
How often do you all review your prior authorization list to determine whether or not an item should still be on it?
Annually.
Is that for everybody? Annual?
Annually, and more often if needed, because sometimes there's something that we realize, let's say 95% of the time we're authorizing anyway. So we may consider that more of a low value to continue to do that, and can then take that off the list for prior auth.
Okay. All right. So I want to ask this question, but I feel like it's going to be complicated. it's about medical loss ratio and how you all calculate it. We're trying to get to sort of, in some cases where healthcare finance has one number, and then you all say, oh, wait, we have another number on the internal side, and we're trying to figure out how we reconcile the two in terms of how healthcare finance is calculating some of these versus how you all are calculating it internally as well. And perhaps that is a question better for offline conversation. Because I think we just want to understand this better. In the same vein, I would say that's the same about calculating profits. And, you know, the operating margins that you all are working with in terms of revenue versus claims versus administrative costs. We have the data from healthcare finance, but I know for some of you, you think that the number is wrong from healthcare finance. And so what is the process for you all to, what is that? Contest, appeal the number? I'm not really sure on that front. Any thoughts?
I would say that we didn't have any discrepancies, but I think I would say that the differences are about the report in the reporting periods, right? So the rates are approved and calculated within, you know, the government fiscal year, the DISB statements. This is what the MCO performance oversight report is based on the calendar year.
Yeah.
And we internally work within our fiscal year. So there are 3 different reporting periods, 3 different numbers, you know, 3 different ways of looking, you know, slicing the same kind of set of data.
Okay, that I understand.
And council member, I would also add, we're still also undergoing an MLR audit for FY23 and 24. So there are still things going with Myers and Stauffer.
Okay, I'm looking at calendar year 23 data. So I would assume is right? No? No. These are based off of MCP annual statements as of December 31st, 2023, filed with DISB.
We've not had a concern about a discrepancy.
Okay.
To my knowledge, we have not either.
All right. Then now that we have that sort of on the basis, let me sort of ask some questions. Okay. So we'll go down the line here. Okay. So for MedStar, revenue was about 411 million. Claims were about 379 million. Administrative costs was 12 million, which your administrative costs are the lowest out of everybody, which I'm curious how you guys are pulling that off. And so your OM, your operating margin was at about 19.6 million. HSCSN, your operating or your OM was 11 million. You have about an $18 million administrative costs. AmeriHealth, now you guys have the bulk of the population. It's about 51.9 million in terms of administrative costs. And your OM is about 33 million. And then AmeriGroup / WellPoint, administrative costs is about 25.5 million. When you all calculate your administrative costs, what are we including in that? Obviously, that's people, your staff. If you have a physical location, which I think all of you do, that's included in that as well. And I guess whatever the costs are required to keep up that, whatever that physical space is, might be paying for internet, phones, utility, et cetera. Is there something else in administrative costs that normally people would not associate with administrative costs?
The back office functions, so we're paying claims. We, you know, we have legal, so there's a whole host of I would call them back office functions that are part of the admin buildup. So it's comp and non-comp supporting functions.
Okay. Anybody else?
The same for us, shared services.
Shared services, okay.
Yep, agreed, same.
Do you have your shared services in-house?
Yes.
Okay. All right. I'm out of time. Trying to be respectful. Councilmember Parker, we're gonna put a pin in that. We're gonna come back.
Thank you. Any update on those numbers, or you're gonna need more time? Okay, we're gonna assume you need more time. But again, wanted to know more information about reversals on approvals and denials. I wanted to come, one thing, I know we're still awaiting guidance from healthcare finance, given some of the changes that were made in this last budget relative to who's covered under Medicaid or who's moving to this Plan B plan, as well as other things. Can you all just at a high level speak about internally how you're preparing for the adjustments in our landscape and or how you might conduct outreach with your members?
I can start. So we are doing regular implementation meetings for the basic health plan, which is what you're referencing, which starts January 1st. We have a suite of team members from operations to community outreach to provider network. We have weekly meetings where we are preparing for that. As far as education to our members, we're using various modes of communication. I would say text messaging, web-based platform, outreach, face-to-face outreach, partnering with community providers as well as with providers, so that we can educate members not only on the basic health plan changes, but also on the alliance that is leaving the managed care program as of tomorrow. So we are deploying as many modes as we can to ensure that our enrollees are informed and working with Department of Healthcare Finance.
And you're feeling confident come January, members are going to be in good shape?
For MedStar Family Choice, I do feel confident.
Yes, others want to weigh in?
I agree with all the things that have been said. In terms of the alliance, we've had a bit more concern because of the presence of people who don't believe they're U.S. citizens and want them gone. So we've taken the extra step of letting them know that they can come to our office to ask questions. We have a large component of our team that speaks Amharic or Spanish. And so they are able to support them in understanding fully, even though the material is translated. Sometimes it's just a matter of understanding, so what do I do next, or how do I resolve an issue or a concern? So people have been coming and getting that level of support. I've also personally been sending information to the community-based organizations because they were later in understanding, but we know that they have, one, they're trusted, and two, they are reliable communicators in the community to people who need to know. And so sharing information with them, as well as all the other things, we think is going to have us in better stead. However, we are also prepared that if someone is still confused and they look at the number on the back of their card and they reach out to us, all of our enrollee-facing teams have been educated to support still answering questions so that people know what to do.
And Councilmember Parker, I would concur with both MedStar and AmeriHealth. I feel like these meetings are almost daily on the transitions for both of the programs, those who are going to the basic health plan as well as the Alliance going to fee for service. But I did get you your answer. We can do a deep dive on this. But for this year, for those denied then paid, it was about 2.4, 2.5% were reversed.
And just to be clear, that's reversed. They were approved and then?
No, they were denied and then the provider appealed, and upon appeal, 2.5% were reversed.
Do you have the other number where it was approved and then denied?
I don't have that one, but if we don't have it by the end of this hearing, we'll make sure we get it to you in the committee.
I really appreciate that.
Follow up, Councilmember Parker.
Yeah, I really appreciate that. And here's a offer. Use members of the council to be a part of that process. I know Councilmember Henderson and I teamed up, seems like forever ago, a couple of months ago, to kind of do a primer for Ward 5 residents about, hey, here are some of the changes coming. I know we only scratched the surface, but I think between the members of council and the work that you're doing, we could reach many more people. I continue to be worried that there's a seismic shift coming and a lot of people are going to be blindsided by it. So thank you for the work that you all are doing there. Some other specific questions, and then I'm going to likely give some time back. Ms. Dale, in your responses, you state that there are over 16,000 members without claims in the past 3 years and 20,000 members without claims in the past 2 years. Can you speak about how you're contextualizing these numbers and any outreach that's being done?
Sure. So the first context I would offer is that we have 120,000 members. All programs are voluntary. We have a high proportion of our enrollees that are children. So we want them to go in for care, but their parents may not take them. So there's a dependent factor there. We do a lot of outreach. As I've mentioned, our strategy is very much about being embedded. So we're in over 40 affordable housing properties through our partners. We are in the high volume, where we have a density of members, provider practices, hospitals, FQHCs. We are present in as many spaces and places as possible. One of the things that our healthcare delivery system can do better is to offer care in a way that makes people want to lean in. So many of our enrollees, where they sit on the federal poverty level, they're often working 2 jobs, right? And so when the provider visits are only offered 9 to 5, a choice that they are forced to make is to lose income. The district has one of the highest child care rates. And so our members are always making this choice. And I know this because we have those conversations. And so we look to providers that we can get to have evening hours or weekend hours. When I talk to our enrollees and ask, what is it that makes you go to the emergency room? For them, it's convenience. It's not the right place of care, but it is convenient. And with the choices they have to make to lose wages, they choose to go to the emergency room where they can get everything done. They're going to get blood work, an x-ray, all the things. And so many times, so that would be a claim, but many times people just avoid the system until they get to that point where they must. And to me, that's a larger issue for us to solve, that providers will have more evening hours and or weekend hours. There's a provider that's part of our provider advisory committee, and we were talking about this, and he said, I'm happy to do weekend hours. We just have to figure out, how we can make sure people show up for the appointment because he doesn't want to have his staff all there. So we do provide transportation to appointments. We make it easy by people being able to use Lyft. So it's a shorter time, right? Because it works just like if you or I were to call Lyft. But these are the types of shifts and changes that we continue to work on to make things easier, lower barriers so that people are more likely to lean into care. I'm particularly concerned that our immigrant population is shying away from care, right? Or has shied away from care. So it's work to be done. We will continue to ideate and work with our partners to identify mechanisms to get more people into care. However, it's voluntary. It's a benefit that we have. We have the richest benefits, in DC. We have a lot of programs and services. We simply have to keep figuring out ways to ensure people know about them.
Awesome. Last question. And I believe it was Healthcare Finance Audit Report. It found that managed care plans spent about $90 million on patient care that could have been avoided through more aggressive care originally. In fact, the 30-day readmission rates for across plans was incredibly high. Can you all speak to how you're IDing that number, the 30-day readmission rate, and what progress, if any, you're seeing and ensuring that there's a decrease there? And I would just note while you're thinking about it, like often I hear the retort that we don't always have a healthcare system. We have a system that kind of treats symptoms. And I think at the heart of that is how patients are feeling when they go to the hospital and then they have to go right back for the same thing. So not to put anybody on the spot, but I thought that number jumped off the page to me.
I'm happy to start. So the 3 pay-for-performance measures, I think one of the witnesses talked about that, are 30-day all-cause readmission, low acuity non-emergency room visits, and what's the other one? Potentially preventable admissions.
That's right.
In the district, over, let's see, 4 mayors and changes in council members, we have not kicked people out of Medicaid for introducing waste in the system. We have not. I'm not saying we should. I'm just saying there's no consequence no matter how many times you go to the emergency room versus utilizing your provider. So the burden is on us to make sure that we are educating more, providing other options.
You wouldn't be blaming the patient.
No, that's what I'm saying. The burden is on us to educate more, give people more options. Like, it's really a barrier not having more providers that are able to offer evening hours. So we work to incentivize providers to do that and provide weekend hours. There is confusion when people even go to urgent care because some urgent care centers have more robust set of services and others don't. So if someone requires an X-ray, they actually may need to go to a hospital because the urgent care that's closest to them doesn't offer that, right? So there's a lot of complexity in the why people go or go back. In terms of readmissions specifically, we see a higher number of people going back for readmissions for behavioral health conditions. We've seen that worsen over the pandemic and after. And so we have a lot more interventions where we are focused on partnering with others that are providing another part of the continuum to help with behavioral health conditions. Like I mentioned, the pharmacy piece, right, where we have a partnership with a pharmacy to help with the long-acting antipsychotic drugs, because that helps to prevent a readmission. So we are matching interventions to the reason people are getting readmitted. Our persons who are experiencing homelessness are more likely to get readmitted. Again, we have interventions with community partners to help with that, where they are respite housed and get support and services that are more meaningful at that time.
Thank you. For the sake of time, I'm going to end it there because I am over time, but thank you all for your testimony.
Thank you, Councilmember Parker, and thank you for being here. I want to pick up where he left off around readmissions and those kinds of things. So how often are you all probing, as the head of your plans, probing some of this information, right? Like, can you drill down on how many patients are actually responsible for the majority of readmissions or those types of calculations so you could sort of understand more deeply? I remember having a conversation with the head of the sickle cell center at Howard, and you got like 200 people in the city who were responsible for 40% of the readmissions specifically related to their disease. And so having to sort of think about what does care management kind of look like differently for those folks. I'm trying to understand, is this type of analysis happening?
I'll jump in there. Absolutely. It's happening on a regular basis. There's various means where we do it. For instance, we do a monthly market review where we look at all of the analytics and data, such as ER readmissions, and who are basically, for lack of a better term, our frequent flyers.
Yeah.
Our case management team is in the room when that happens. If they see it, that's the next person on the list to have a case manager reach out to, or a CHW knock on their door to try to get them into care. So it's something we look at regularly, and we take it very serious. In my testimony, I mentioned that's how we've seen some of these declines. By just being on top of the data. But then also you had asked a question about care coordination, partnering with the providers as well so that they have the same data that we have, so that they can act as well as we can act.
Okay. About how many people would you say are in your frequent flyer category?
Approximately 30 asterisks, because some of those do need those services.
Yeah.
But the list, which we see high utilizers, is about 30.
30, okay.
We review on a monthly basis as a plan, but we have ongoing rounds, and as well as twice a month, the medical expense committee, where we dive into the numbers. I also wanted to address the sickle cell. Sickle cell patients account for the larger number of readmissions, and actually some of them are avoidable. And because of that, we have a value-based reimbursement program and the quality improvement initiative with the sickle cell clinic at Children's Children's National, where the majority of our patients go, actually to standardize and coordinate better the disease management between the health plan and the clinic, and to prevent some of the avoidable readmission.
Okay. Karen?
The same. We have a weekly readmission rounds as well, where we are working on how do we problem solve for the reason the person, right? And it varies. A lot of times some of it comes back to social risk areas. It's one of the reasons why we invested in helping to launch a medical respite program, because those enrollees were not only being readmitted frequently, they were sicker each time they were readmitted. And so we know that having them stably housed with that first portion of the program focusing on medical stability is really important to not having people be readmitted.
Are many of these folks either unhoused or unstable housing?
Yes.
Okay. About how many, in Mr. Jordan's term, frequent flyers do you guys have?
We're, larger, so we have a larger percent, but I would say somewhere around 70 to 100, depending on the time of year. Because
I think like out of the 240,000 people in DC that's a manageable number, right? We're talking about a small number of folks who are accounting for millions and millions and millions of dollars in costs. And if we could solve it for these folks, then I feel like, not that we should give ourselves a badge or something to that effect, but if we could solve it for those folks, then that means that we might be solving it for some other people as well, if that makes sense.
Yes.
Ms. Carter?
Yes, I'll just follow up on the same thing that everyone else said. What we are seeing as our top readmission diagnosis is behavioral health.
Okay.
So we are developing specific interventions, partnerships with various programs, the McClendon Center, which I think Ms. Dale spoke about. We're also partnering with PIW. We have created a pilot program to incentivize our members to come back for follow-up appointments at some of our behavioral health providers. And to address your question about our high-cost utilizers, we do run that information on a very frequent basis. We have instituted rounds with our clinical rounds. So we have rounds related to readmissions, top 10 behavioral health members, rounds that are led by our behavioral health medical director, as well as we have our rounds for our highest cost members as well. So we are looking and digging into the data. I would say you're going to ask me the number. It's probably right now we ran about 20 people, and we're small in DC, but it's about 20 that is driving the majority of the cost.
See, that's what I'm saying. Like, we're talking about.
We are talking small, but you also have to remember
Small but complex.
Small, right? That's what I was going to say.
And I do recognize that they have the opportunity to sort of voluntarily decide. So this will be my next question, sort of. Obviously, I think, as MCOs, your direct conversations are certainly with healthcare finance, but are you taking some of this information to DBH? Like, if behavioral health is really there, and you guys would know better than most in terms of what is available and not available in the district in terms of the full continuum. Now, I could talk to Dr. Bazran until I'm blue in the face, and I have, about our need to develop, right? I need day centers, I need short-term, I need blah, blah, blah. But I'm not the director of the Department of Behavioral Health. But if they're hearing it from you all of like, look, Mayor, 20 people are accounting for X amount. And if you just had this one other program we could solve, or we can limit, or we can reduce, are those conversations happening?
Yes, for MedStar Family Choice. We're not only meeting, we do collective meetings with Department of Healthcare Finance and Department of Behavioral Health that are led by our Behavioral Health Medical Director. And so she leads the charge for us with coming up with the various interventions, as well as she's made recommendations to DBH and DHCF on just different, things or interventions that we could do.
And have they heard you?
I would say yes.
Are they acting on the recommendations?
Yes. I mean, as what
I'm being serious.
I mean, no. I hear what you're saying, but I still think we have to remember there's another person on the other side that has to be willing to accept the services. We can meet with them, talk to them till we're blue in the face, but if they are, if we can't get them to do that follow-up, so I just think it's, and I'm not putting the onus on the member by no part. I think all of us have a part to play, but I think there are other forces that we have to consider. It's not just, okay, we do this one thing and it's I think there are a lot of things we have to do.
Well, then let me ask it in a different way. It's on the behavioral health question, because one of the things that we saw on the DBH data side on behavioral health was that there were a lot of people who were using telehealth in a way that was a lot. Telehealth behavioral health services. And so DBH decided to change the limits in terms of how much someone can get on those types of things. When you say behavioral health, I don't think you're referring to telehealth. I think you're talking about emergency room. Is that
correct?
Okay.
Yeah, I'm talking telehealth.
Adrian, you said the same thing in terms of behavioral health, but I think you're talking about physical going in for a visit type of situation. Okay. I feel like this is something that I want to try to unpack a bit more. And we're going to send some follow-up questions. I want to better understand, the data and the communication, because even on our side, I want to share it with my colleagues who may be running, they chair other committees or sort of things like, I think it would be good for Councilmember Parker to know if it's like, how many of the young people or youth affairs but also what are the missing links? Like, if it is hey, I have to go to the emergency room because there is no other provider in DC who is able to do the thing that I need. And so I go to the emergency room type of deal. I will say this, I think that at the beginning, whenever the numbers come out for calendar year 25, especially Q1, all of y'all are gonna be messed up, because what we saw happen at Cedar Hill, where 80% of what Cedar Hill saw in an ED in Q1 was all non-acute things that could have been handled at urgent care, right? And so everybody's numbers are gonna look a little funky at the beginning of this year, particularly when we're talking about patients who've traveled to Cedar Hill or who are east of the river on some of these things. But let me just talk a little bit about care coordination for a moment here. How do you all distinguish between case management and care coordination? Or is there a distinguishing factor?
We operate using the NCQA definition. So the person has to have agreed to case management. They have to have a clinical person, so a nurse or a social worker, complete an assessment and work with them to create a care management plan, and then have specific goals that are measurable, that throughout the course of working with that individual, those goals are assessed as met or incomplete, or, so there's a specific working through on all the goals. Care coordination, on the other hand, is helping that person to navigate the delivery system. So you may help, so it usually doesn't have to be a clinician. The person is being assisted to make appointments or to be referred to certain supports and services that helps them to work through, or like maybe they went to the pharmacy and their prescription didn't get filled. Like the person helping with care coordination can help them to say, oh, you know what, your doctor didn't do this. You just have to talk to your doctor, or if you want me to be on the phone while you do that. So they're helping them with connecting to things that they need connected and resolve issues that might pose as barriers. And when you have good care management and good care coordination, the person usually has a better shot at navigating the system and getting to what they need at the right time.
Does everybody else have the sort of standard?
That was a great answer. So
Yay, Karen, on that one. Okay. Hold on one second. Okay, so the two measures that district MCOs did not meet their targets for in-network adequacy for FY 2024 were around adult PCP urgent appointment compliance and pediatric PCP urgent appointment compliance measures. How are you all working to improve these targets?
Our members report when they're not able to get an appointment.
Okay.
We replaced our nurse triage line with a service called Imagine Pediatrics that provide not only nurse advice, but also immediate virtual urgent care appointments, and then connect with the PCP.
I want to just add, so when they tell us that, that's when care coordination kicks in to help make an appointment.
Yep.
We also routinely test, just call a provider and say we're trying to make an appointment. For example, that's really important for EPSDT, that children are getting their annual physical. There are times when we call and the appointment's not out for 60 days. So we will call the provider and say, we've got to get an appointment. So we're always working to get providers to have more access. But again, post-pandemic, provider offices have often, they're smaller, they're shrinking.
Yeah.
And some of the high volume providers, the FQHCs are challenged because remember, they're kind of rotating people through sometimes. And some of our enrollees don't particularly like that either, that they're seeing someone different each time. So there's a confluence of factors that affects access, right? Which means I called and I wanted an appointment and it didn't happen within a certain time. And so that's a continued opportunity for us to work with our providers, whether it's around incentives or, to incenting them to have additional hours or those kinds of things.
Yeah.
It's challenging, and it's been more challenging post-pandemic.
Yeah, I would think that more providers, though, would be interested in sort of a non-traditional hour if they had the ability to say, yes, we know this many people are actually going to show up. A couple of weeks ago, I went to the DC Health and Wellness Center, so it's run by DC Health, and we provided them some additional funding for next fiscal year for them to do expanded hours in the evenings and on weekends. Now, it's not every evening, and it's not, both Saturday and Sunday, but they have a dedicated block of time and they're able to slot people into those appointments. And it just truly expands options for folks, even for my own kid's pediatrician. Like when she offered, hey, I'm going to be here till 7, bet I will be there at 6, I will take that 6 o'clock time as opposed to having to do the rigmarole of, let me take her out of school, let me do the thing, and but it's rare that providers are even offering that option, even though I think they actually might have a better show rate if you offered evening hours than if you did it during the day. I don't know. Adrian, do you want to?
The only thing I would add is with our value-based partners, we have provider care consultants that go and embed in the facilities as well. And they can help them see things that they may not see because they're treating our members as they should. So they have, I'm probably going to get this wrong, but at least they meet bi-weekly and they show, hey, this is a national best practice. If you include this, it may increase capacity. So we do have care consultants to go help our provider partners.
Okay. Yes.
Yeah, no, just to answer your question to round it out, in addition to the things that were spoken about, we also offer telehealth services for our members as well so they can have the access. We have our outreach team members who will answer calls and help to make appointments for enrollees when they notify us. And then we have just recently contracted with the new secret shopper so that we can identify those issues and be able to address it with the provider and/or expand our network access if need be.
Okay. I find the secret shopper to be very telling because people will tell you all day long, oh, no, we're following. And then it's like, hey, but I called, pretended to be a patient. And this is what, your front list told us or didn't tell us. So I get that. On case managers, really quickly, MedStar, how many case managers do you employ? Okay, I'm asking you specifically because everybody else answered that question in the pre-hearing responses. And so we just want to make sure that we have a complete piece here. Sorry, I'm thinking around here. Very quickly, in terms of when you all are receiving claims where someone on your staff, like there's a suspected fraud issue, what's your process in terms of, do you go to healthcare finance first? How do you all report it? What's the reporting chain?
So speaking for WellPoint, our SIU division, Special Investigations Unit, they will, using the skill sets that they have, start flagging things. It's not an initial go to DHCF. There's prepayment review, post-payment review. There's steps.
Okay.
If those steps aren't remedied, then they are escalated to DHCF.
Same. All right. Everybody has the internal piece. Okay. Thoughts on the all payer claims database? I'll let y'all marinate on that one. We'll come back to it. Okay. There's so much to get here, and I know that there are probably some people who are feeling very unsatisfied that we aren't able to dig into some of these questions, and we'll send some follow-up information. Unfortunately, I do have to end this hearing. I am on pickup duty, so I need to get to where I'm going. And I don't have another colleague to sort of turn to here. But I want to thank you all for participating and for being here. For those who are watching, we had initially planned to do this hearing in February as part of our performance oversight process. We had to reschedule it, and we wanted to get this in. I do feel like, and this is sort of a preparation for our plans here, is that we often don't just do a hearing that is directly specifically with you guys. Like usually you're testifying before Wayne is testifying as part of their performance oversight process. But we feel very strongly that when you look from a budgeting standpoint, how much money we are spending on your contracts and these services, it does require, I think, more scrutiny on the part of the council to make sure that we're getting the value for how much of what we're spending here. And so that is not to suggest that your companies are doing anything wrong, but for a very long time, we've been doing MCOs as part of managing our Medicaid program. And the council has not been doing its due diligence and sort of asking these types of oversight questions to determine what's going on until something goes wrong. And I don't want to wait until something goes wrong to then have a hearing. Let's talk about it in the process. I also feel like, too, you all have a wealth of information and knowledge because of your touch points with residents and with patients that could help us improve the overall public health system in general. And so we're going to follow up on some of these things, particularly around the readmissions and the potentially avoidable spend. I know that it's not all your fault, because I was even asking my staff, I was like, okay, what happens though in a case where a person went into the ED for feeling chest pains, the emergency room sent them home, and then they turned around and had a heart attack? That's not on the MCO. That's not on the patient. That's on the hospital, right? Somebody didn't listen, or perhaps they didn't see something in that particular time. But I think we need to sort of unpack some of these things, especially as just like dollars are getting tighter. And also people are getting sicker. So we got to figure out how we kind of marry the two. And so I definitely want to talk more about some of that. And then also, the number of people who haven't had a claim in 36 months. Again, I know I cannot make you go to the doctor, but it is also in my interest to determine whether or not this person is phantom or if they're real. Love you guys, but I just don't want to give you free money. You know what I'm saying? Even though I know that for your plans to work, you have to have a certain amount of healthy people in it, which is great. But then I think also, and that's not necessarily a question for you guys, but also a question for healthcare finance in terms of how many of these folks are we passively approving every year and nobody's going back to check whether or not this person is still a resident of the district, even though we're still paying for them. And these are the similar questions that we had for them when we talked about the Alliance program and otherwise. On that, we're going to have a hearing November 20th on the changes around Medicaid and Alliance. At November 20th, I think at that point, we're about a month and a half into the October 1 changes. Guys are not required to testify, but we certainly welcome you all to participate in that conversation, as you are part of some of the changes going on here. And with that, let me find what I'm supposed to say towards the end. Rebecca wrote a lot of questions. Okay, so this concludes our oversight roundtable on managed care organizations in the district, and I want to thank you all for everybody who testified and submitted testimony for today. For anyone who cannot attend or speak, we will accept written public testimony from the public until Tuesday, October 14th at 5 p.m. You may submit your written testimonies at the council's hearing management system, dccouncil.gov/hearings. It is 4:59 and this hearing is adjourned. Thank you all so much again for your participation.